Good evening, doctors. Good evening, faculties and delegates. Thank you for joining Shield Connect. I am Nishan Chawda, Regional Medical Advisor from Shield Healthcare. It's my privilege to welcome you all for this wonderful series, Trending Ask series, which is organized by AGOG, Academia of Global Obstetrics and Gynecology on Shield Connect platform. And so in this task series, we will cover episode C will cover the topic challenge in management of CA, cervix, and Caesarean. So before we start with the series, let me show the short introductory video for AGOG. So please play the. And with that, let me start the episode with small Vandana prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
So I am happy to introduce the Master of Ceremony for this episode, Dr. Monika Upadant and Dr. Kanchan Prasad. So let me give a brief introduction of Dr. Monika Upadant. Ma'am is consultant obstetrician and gynecologist in Mangalya Nursing Home and Atharva Fertility Center. Ma'am is PAC committee chairperson of AMOX 2022-2024. Ma'am was a website coordinator for AMOX as well as youth coordinator for AMOX in 2020 to 2022. Executive member of PAC in 2019 to 2022. Executive member of ISOBAP. Treasurer of IMA in 2021 to 2022. Solapur obstetric treasurer in 2015 to 16. Clinical secretary in 2018 to 19. And ma'am is instrumental in designing the website and SOG apps. And now also let me introduce Dr. Kanchan Prasad ma'am. Ma'am is professor in TMMC and RC Moradabad, North Zone coordinator of Foxy CRC committee. Ma'am is champion of Foxy Award 2021 and also received Dr. CS Down Paper Prize at AICOG Bhubaneswar 2018. Best Paper Prize in Foxy International Women's Health Summit 2018 Gurugram. Best Poster Prize in International PCOS Conference 2018 Gurugram. Past Joint Secretary of Haltwani Obstetric and Gynecology Society. Reviewer of Index Journals. Ma'am has also various publications in nationals and international journals and certificate course in research publication. So with this, I will hand over the session to our Masters of Ceremony, Dr. Monika and Dr. Kanchan. I welcome you on this platform. Thank you, ma'am.
Thank you for the introduction. At the first instance, I would like to thank Dr. Komal Chavan Madam for giving us an opportunity to conduct this webinar. We welcome all of you to the series C of tasks, that is Trending Ask series from A to Z. This series is specifically targeted to cervical cancer prevention and cesarean section. Let me take pride in introducing Dr. Komal Chavan Madam. She is the convener and the program director of this series. She's a medical director at Chavan Maternity and Nursing Home, and she's a senior consultant, a DND teacher, unit chief at VNDSI Hospital, Mumbai. She is also the ex-honorary professor at Arun Cooper Hospital, HBT Medical College, and a chairperson of Foxy Medical Disorders in the year 1922. She has been the zonal coordinator for Foxy in the year 2023. She is also the chairperson of AMOX Family Welfare and MTP Committee in the year 22 to 24. She is a member of Managing Council of Mumbai OBGYN Society, Joint Secretary ISOPAR Mumbai Chapter, and the Premises Secretary of AHG. She has many national and international awards to her accomplishments. We welcome you, ma'am.
Thank you.
And
Thank you.
ask you to.
Yes.
Thank you.
Thank you, Monika. And it is really great to see everybody and meet everybody, connect on this platform for Trending Our series. And the idea behind starting a series, when we talk about series something, then it becomes little bit, you feel the urge to learn, or it is another way to gain knowledge. And that was the concept behind this series. And series C, as we say, we talk C means challenges, but challenges in managing cervical cancer, which is the biggest challenge for India, and the Caesarean section, which I think it is becoming challenging because we need to understand about it more and more, seeing the incidents, the rising incidents. And that was the idea of having these two talks. And I thank all the esteemed faculties who have joined. I'm really honored to have presence of Dr. Sanjay Gupta sir as a chief guest, Dr. Neerja Batla as a guest of honor, and our two talks, which will be given by Dr. Priya Ganesh Kumar and second by Dr. Manoranjan Mahapatra. We have this galaxy of all the speakers and panelists. So our chairpersons, Dr. Pam, Dr. Mamta Dagar, Dr. Vamsi, Dr. Nikhil Parvate, and our panelists, Dr. Kiran Pandey, Shashwat Jani, Vidhu Modgil, Rekha Rajendra Kumar, Meeta Gupta, she's come all the way from Jammu. I'm so happy to see you. Shama Devsana, the younger one from the south. We have from all the poles, people representing Guinea Gupta and Dr. Ranjana Joshi, and our two coordinators, Dr. Kanchan Prasad and Dr. Monika. So thank you so much for meeting. And I would now like to take pleasure to introduce our chief guest. So may I have Dr. Sanjay Gupta sir's CV? We all know sir. Sir is a great academician and a very, very great human being. He is a stalwart and a legend in himself. And we know that he is the ethics committee ex-chair of PIGO, the international organization, also the Secretary General of World Justice Organization. He's been awarded the FRCOG Honoris Causa by the Royal College in London in 2010. And he has represented us in FOXY, and we still remember his wonderful year as FOXY president way back in 2010. He's also the president of DIPSI, the Diabetic in Pregnancy Study Group. He's been the chairperson of Technical Research Committee of Indian College of Medical Research, and has been author of 8 books, almost 150 publications, and really a very dynamic person. And he also has this one forte, that is gene arrow, genome research and solutions. So I think this is something which sir has his own masters and he's been talking about it so much in depth about that subject, and we have learned so much about that subject from him. So we are very happy that he has been there today and accepted our invitation to be the chief guest. So I welcome sir and request him to kindly address our audience. Unmute, sir. Yeah.
Thank you so much, Dr. Komal, and it's really great to have all of you here, Komal and her husband. We were better off or what? Both are very academic, and they have this wonderful series and doing such a lot of work in this field. And I think one thing we learned in COVID is not only to work from home, but also to learn from home. And thus these kind of series really take us to a great knowledge sort of lectures and associations and presentations. Today also we have two wonderful speakers, Dr. Priya Ganesh, who has done fantastic work in cancer screening, and she is now as a chairperson of the oncology committee, taking her work everywhere in India and also abroad, and coming up with wonderful guidelines what exactly to be done, and doing a lot of training. And also we have Dr. Mahapatra, who has worked in this field hugely, and combining the Caesarean section and so obstetrics and gynecology together, that's a master stroke, and both are very practical aspects, Komal, and I really appreciate your, thinking of bringing these things together. I won't go on naming everyone, but so much all enthusiastic, Foxians here with us, and I'm looking forward to learning from all of you. So definitely, please go ahead. Dr. Neerja, I think she has joined. She has also done a great work in this field. So I think her comments about this will also be important to all of us. Thank you so much, Dr. Komal, for having me here as chief guest.
Thank you. Thank you so much, sir, for your kind words. And I have with me my co-convener, Dr. Niranjan Chavan, and I would request him. We know he is the president of MOG, joint treasurer of FOXY. So, Dr. Niranjan Chavan, can you please introduce our guest of honor, Dr. Neerja Batla?
Yeah, thank you. Thank you, Dr. Komal, and thank you, Dr. Sanjay Gupta, sir, and all the members who have joined today, the panelists, the moderator, and the master of ceremonies who have been here. The whole idea of this academia of global obstetrics and gynecology was started in 2019 at the AICOG of Bangalore. So the patron and advisor is Dr. C.N. Purandare, sir, and we decided that we should have each representative from each of our continents. And just to give a brief idea, sir, because very few people are aware of this, and that's what now we have done this for 5 years. We did in COVID also, sir. You are all aware that in COVID, we have done so many programs, and with Shield Connect, this is our second stint. The first stint was last year, and have come out with a journal of obstetrics and global obstetrics. So the lectures are not only for the lectures, but these lectures will also be printed in this journal with 2,500 words. So I would request Dr. Priya Ganesh and Dr. Manoranjan Mahapatra and the other speakers like Ruby Ruprai and Sejal, and last when the episode B was there, we had Dr. Madhuri Patel who spoke on the breastfeeding, and also our one more esteemed speaker was there, Dr. Komal, who was there.
Dr. Pai, Murlidhar Pai.
Yeah, Murlidhar Pai. So all of them are giving their, in the next 15-20 days, their inputs for this journal. So we will be also sending the journals as a soft copy to all the members who are attending. Right now we have got 1,500 members. I remember during COVID, sir, when you were used to also come there, Gupta sir and Neerja madam, we did the first case of COVID, which was delivered at AIIMS, New Delhi. And I'm really thankful that Dr. Neerja was a part of, the SOPs. And thank you. Hello. Hi, Neerja and Sanjay, sir, that all of you were contributing that time, and the show must go on, because it is very important that we give knowledge, and we have so many stalwarts which are there. Posts are going to come and go, but the amount of efforts and the works which has been done by each of us is going to be remaining for a long time. And today the topics are, as you said, Caesarean sections. Even CN sir, that day, sir, we had the MOGS annual conference, and Frank Lowen sir had come, how to deliver vaginal breech delivery and to reduce the sections for primary breech. So he has done about 2,000 normal vaginal deliveries by breech. So the idea is also to reduce that incidence of breech delivery for a cesarean section, and also to lower the incidence. And we need to do something about it, sir. So I request you also that AIIMS and Gupta sir and others who are there in the institute practicing as a professor, and sir, you have your own research center. We need to do something for the next 10-15 years, or at least the next 5 years, to reduce that incidence, and how we can teach the instrumental vaginal delivery. So I think it's a very important topic. And thank you, sir, for being there. I would like to introduce Dr. Neerja Batla, madam. She is the most senior person, and we are very proud that she has represented us in FIGO. And in 2012 and 2014, she has changed the FIGO classification of carcinoma of the cervix. There are many textbooks which she has written also, and presently she's the head of the department of AIMS. I was very fortunate enough last year to be the external examiner with Dr. Neerja, and I have seen the students, the research work, the quality of the thesis which they have maintained. It's amazing, madam. And you being at the helm of affairs, it's really very happy to see that #1 institute of our country is AIMS, New Delhi, and we always look forward for you and your guidance. She has been holding so many positions. She has been president of almost all the gynec associations of the world, and I'm really happy that I could also associate it with her as an oncology chair when I was there about 10 years ago. So welcome, madam, to be our guest of honor. I request you to please speak and guide us and encourage us.
Thank you so much, Dr. Niranjan, for that very kind and generous introduction. And thank you, dear Komal, for inviting me today for this very important session. And it is so nice to be on this here. Dr. Sanjay Gupta, my salam. I'm seeing sir for so many years now. Even when I was there, he was very encouraging. And Niranjan, of course, was my predecessor. I learned a lot from him about how to do things in Foxy. And he started the colposcopy course with so much passion. And he followed it even after he had finished his chairpersonship. And he was a really example how, the passion that drives a man. So I think we have all learned a lot from each other. And we're very fortunate to be in this era where cervical cancer elimination got so much thrust. And I always say it was a good thing that it happened before COVID came, because after that, I don't know, again, it would have got sidelined. But since Dr. Tedros had committed before COVID came that this is going to be the flagship of his tenure, that he will ensure the cervical cancer elimination. And then that thrust continued throughout. So now it's a very, very amazing situation we are in after decades and centuries of living with no hope. How we'll do, even LMICs and everyone has new hope that this is something we can do it. And many people talk about how cervical cancer incidence is declining, which it is. And we should recognize that this is the right time when we have to strike for elimination, because it is not good enough. What is happening on its own is neither it is good enough and neither it is a guarantee that it will not rise again. Many countries, including Japan, some areas in China, they have witnessed that they have had decline and it has gone up, as it is possible that it is the changing practices and the attitudes of the younger generation, the increasing migration. So many factors may be responsible, but be that as it may, our duty as doctors is not to sit in judgment, but to assure safety of the person, whatsoever may be their choices. That is a separate thing. That is not for us. We don't have to sit in judgment on any of the issue. So we have to ensure that they are safe. And that is what is the essence of the elimination targets. So it's great that we are talking about new HPV tests. I knew Dr. Gupta himself has his lab developing an affordable HPV test. Then we have the vaccine, which is so affordable around the corner now, second half of year, they have promised that. But also is the very sober realization that as we step out into the field with a proper and expanded program for first time, literally, I mean, half the districts have started VIA program, but we all know it's patchy, it's not linked properly with treatment and the follow-ups are poor. So once we really do this with momentum, we will find a lot of patients who already have cancers, which are undetected, advanced stages. And so the treatment has to go hand in hand. The capacity building for patients to receive radical hysterectomy in every district, medical colleges are now going to be in every district. So even there, and the palliative care, every gynecologist has to bring into their thinking, because every woman has the right to live with dignity and comfort. And so even if they are diagnosed with advanced disease, how are we going to? So even I would say every society has to have the knowledge of what is in their area. Where can women go? How can they access services? Which NGOs can we collaborate and provide information to our members that these are the NGOs who are willing to help you? So many things we can do. There's no limit to how much we can do, no matter which aspect of gynae we look at. But this, I think, is part of our humanitarian effort, that no matter what is our specialization, just make sure every girl who comes your way, whether in the clinic, out of it, knows that she has to take her vaccine. Make sure that every woman you know knows that she needs to take the screening, and make sure they understand that a test positive is not to worry about, just to get it followed up, managed, and do it and put it out of your head. Don't keep dwelling on it. Don't let it become a psychological issue, but know that this is the date, I have to go back, I have to do the next one, and make a nice timetable. So thank you for calling me here. I can see Priya also, she's doing great work. We are very proud of all the work in our committee. After me came Bhagya, after Bhagya came Priya. So here's a whole, we have our own family tree here going down the generation. So it's really nice that we are all still united, because we all have a common cause to work for. And Foxy, all presidents have been so supportive, and everyone has recognized the importance, no matter which may be their own interest. So I think we have already showed what we can do in the field of maternal mortality. Foxy has contributed hugely. And here also, I am confident that Foxy will contribute to this elimination target. So thank you for inviting me today and for making such a wonderful program, and wish you all the very best.
Thank you, madam, for your encouragement and your words. I would like to add here that on 10th of October, 2022, Foxy, along with AIMS, along with Ministry of Health and Family Welfare and WHO, we had a workshop and a white paper which was drafted by Dr. Neerja Batla and the team, along with Dr. Shanta Kumari, the then president of Foxy, and CN Purandare sir, myself and Madhuri Patel. We were there on accelerating the management of cervical cancer and introduction of HPV vaccine in the universal immunization program, and to give it free of cost to school girls and from the age of 9 to 15 years of age, and thereafter to the reproductive age. So I would like to hear, say that Dr. Neerja Batla and her team of AIMS, along with Foxy, have given, I think, madam, you might have submitted by now that white paper draft, and that is the, we were all told by the ministry that we need to give them a draft, and this was a urgent meeting which madam conducted within 10 days time, and it was really a very important milestone which I want to share here, and we are going to get that in soon, probably in the range of 400 to 500 or whatever the present, because the government was very happy with the COVID vaccination infrastructure which has been already laid down, and we are given more than billion of vaccines vaccination in the last 2.5 years. So that was the baseline for which they wanted to do. So thank you, Dr. Neerja, and all the your efforts, and we look forward to see you further also committed along with Dr. Sanjay Gupta sir, who was also the chair of the FIGO ethics committee, and we will always need your guidance. Welcome all the members. I would like to thank here Dr. Monika. She's so enthusiastic all the time. I find her in most of the webinars, Dr. Monika. And what can I say about Dr. Kanchan Prasad? Always energetic and dynamic, and you all are the future of Foxy, and we are going to see all members being there with Dr. Pam Sao and other members. I have met Dr. Manoranjan Mahapatra in one of the panel discussions at the AICUG. So with this, I would like now to hand over the mic to the Master of Ceremony. Without much ado, please go ahead. Thank you so much.
Thank you, sir, for the words of appreciation. I now declare the inauguration ceremony as over and we move towards the academic session now. The first session, can we have slides of the chairpersons, please? The first chairperson for today's session, Dr. Sashika Bhosle Saur. She is the president of Obstetrics and Gynecology.
Ma'am, you're on mute, ma'am.
Monika, unmute.
Thank you. Yeah. Thank you so much. And I'm very privileged to be here with you all and to be with Gupta sir and Neerja Patel ma'am is a dream come true. And thanks all to Niranjan.
Hello,
and
we welcome you, ma'am.
Yes. Now I would like to
Can we have the next slide?
Yes.
Hello? Yeah. Am I audible now?
Yes,
Monika,
ma'am.
you're-
Yes,
yeah.
ma'am.
Our next chairperson is Dr. Mamta Dagam. She is a senior consultant and professor at Ripma Institute of OBGYN at the Sir Gangaram Hospital, New Delhi, India. She is the secretary ISOPA Delhi chapter for the year 21-23. She is the co-chair of the training committee of ISCCP 21-23. She is also the member of Breast and Cervical Cancer Prevention Committee, the Endoscopy Committee of EOGD, and the Practical Obstetric Committee FOXY 21-23. She has been the past secretary of EOGD in the year 22-21 and the treasurer of ISCCP. She is also the clinical examiner at Emerson Part 3. We welcome both of you to chair this session.
Thank you. Yeah, thank you, Dr. Monika. Thanks for the very kind introduction. And I'm really very happy to introduce the first speaker of the session, who is none other than Dr. Priya Ganesh Kumar. And Dr. Priya Ganesh is well known, I think, to everyone in this forum, but it's my humble duty to give a formal introduction of Dr. Priya Ganesh, who is the chairperson, Gynae Oncology Committee, FOXY, and medical director of Sai Nivas Healthcare, which is a chain of preventive oncology centers pan-India. And Dr. Priya Ganesh has held several important positions, both in FOXY as well as in Thane Obs and Gynae Society. She is a WHO, IARC, and IFCPC certified colposcopy trainer for India. And she has held several courses, and she's really very instrumental in organizing all the colposcopic courses pan-India and has trained more than 1,000 gynecologists in India. And she has had several awards and publications to her credit and has written books in colposcopy. She has, publications and articles on colposcopy in FOXY Focus and various international journals. And as I said, the list is endless for her awards, but just to mention a few, she had been awarded with Thane Gaurav Mayer Award in 2016 for preventive oncology, as well as National Award Z Hindustan Swasthya Award in the field of preventive oncology by Union Health, and Healthcare Pinnacle Award 2022 by Metropolis Healthcare Heroes Awards. So, Dr. Priya, without further ado, I would request you to start with your presentation, and the viewers are eagerly waiting to listen to you. And
thank you, Mamta.
Updates in screening and preventing cervical cancer. Over to you.
Thank you very much. At the outset, let me thank Komal and Dr. Niranjan and the organizers to invite me. And thank you, Gupta sir, for their very kind words and encouraging words. Dr. Neerja, really thank you very much for the kind and encouraging words. So now the task given to me today is updates in screening and prevention of cervical cancer. It's quite a big topic, but let me try to do justice to this. And I bring greetings from Mumbai, from my center. And a wonderful, beautiful truth. I like to start my deliberation with this wonderful statement that I think women are foolish to pretend they are equal to men, but actually they are far superior, isn't it? And have always been. And that's exactly where our ladies also, our patients also are. They come to us in the late stage. We have to really now pep them up. And so cancers are talking loud. They're very loud to say. That's very easy also to detect. One biopsy le liya ho gaya, but we do have a lot of, the onus rests on our shoulders, the shoulders of the gynecologist per se, because we are the first people to see the patients as well, where we can actually identify the submerged tip. And look at that, look at this difference. It's almost, for one cancer, there might be about 15 to 20 precancerous conditions. And hence it is our onus that we do not want to portray India to be 1 out of 4 in the global having cancers and all that. We don't want this statistics to arise. And definitely everybody, I know Dr. Niranjan Chavan also during his post, so many efforts were put. Prior to that also, all the committee chairs have really put a lot of efforts to see to it that we really have a little, so now the rates have reduced, but because we are a populous country, ASR has reduced, but populous country hone ke naate, we are still having this sort of this thing, the breast cancer is the first, and then this is the Globacon 2020 wala. Cervical uteri is contributing to 18.3% of the overall female cancers. And hence we do not want, now we can really, as so many efforts are going around, we can actually reduce this. And other cancers are emerging, ovarian cancers, all these cancers which are again silent, and these cancers are also emerging. And when we talk about mortality, incidences and mortality, this is from Globacon 2020, what I've taken. So the breast cancer incidences, it is 25.8 per 100,000 women. Cervical cancer is 18.3 per 100,000 women. But look at the mortality difference. The mortality being 13.3 per 100,000 women. Due to cervical breast cancer, and the cervical cancer is 11.4. So the difference is very marginal. Whereas the incidences is quite, there is still a gap of 7 or so. So why is that? Because we definitely seeing the cases at the late stage. Whatever we say, said and done, screening is still not taken up. Vaccination is still not taken up the way it has to be taken. And so our focus is more on that. Now, this was the 2018 Globacon, where you can see deaths were 60,000. Now it is 77,000. So there has been a raise, but proportionally there is also a population rise, and that's also one of the reasons. When you talk about, now this is from one of the latest articles of 2022 National Cancer Registry Program, and it is shown that the cancer cases have now is 79,103 the incidences, and you can see the cumulative risk of cervical cancer in a woman is 1 in 75. So this is a wonderful paper, and I thought it is very, I was going through this article and I was really intrigued by the by their exponential data over here, that what they see in 2015 and 2020 and 2025, and you can see over here exponentially there is a growth. And all the, now this was one of the, this thing where, all the states have shown an increase. So now, as Dr. Neerja had said very correctly, Dr. Tedros had come in his tenure with 90-70-90 slogan. We are all aware of it, the 90% coverage with vaccination, 70% with a high performance test, screening test, and 90% of those screen positives to be treated. So knowing this program very well, we now have to now understand what is, see, we know it, but how do we implement it? That's very, very important. Now, so we know this, that's a development of cancer, mein HPV ho raha hai, there can be cytological changes. What will happen? Then we see this changes on the tissue from colposcopy, and then we treat it and all that. Now, this was one of the trials, which are Sudanga trials, which showed that not every CI need not be treated. You can see if this not treated, and what happens? There is a regression as well. So CI and 1 and all, we usually don't treat. But in our country, because the follow-up is not there, that's again one of the most important things, that follow-up nahi hone ke karan, ya to they go for doing a hysterectomy, which is unnecessary because it's a fear. And what Dr. Neerja said it very correctly, look at the psychological fear having an HPV. It's such a psychological fear, even for, I see so many, because we are per se dealing with this preventive oncology in all our centers. We are getting patients who are even our gynecologists, who are coming to the center. Even gynecologists, if they have an HPV, the first thing is, oh my God, remove the uterus. So my humble request to all of you is, see, what she said was very correct, just forget it. Don't keep it in your mind and keep on muddling around it. We just know that having an HPV always doesn't cause a cancer. So it is that which we have to focus now, so that we are in the green zone. Now, when we talk about vaccination, there has been, so Ian Fraser, we all know, was the Australian, he got the Australian Year of the Award for inventing HPV vaccine. Now, why should you talk about vaccine? Now, a vaccine is very, very important because even before the sexual debut you're giving to those girls, and they're getting that very good response before, that adolescent age. So their antibody levels are very high to protect it. Now, we have various types of vaccines also. Now, since they do not have the natural HPV, doesn't give, the immune response the way it has to be, it's only weak immune response. Hence, you have to give VLP type. The vaccines are what? They are VLPs, virus-like particles, which induces the CMI and humoral antibodies, and these antibodies are then going into the local areas wherever there is a site of infection, and hence they are preventing or neutralizing the upcoming viruses. So now we do have different types of vaccines. You can see over here, we all are aware of it. There are quadrivalent vaccine of Gardasil, nonavalent vaccine of MSDs, and Cervix, of course. Now the new batch is coming up. That's what I heard, but then otherwise it was now out of stock for a long time. And then the Serum Institute of Indian, SIL is coming up with the Cerverac, which is yet to, it has already been declared, but it has yet to come up in the market. So knowing this fact, now this is another understanding of nonavalent versus quadrivalent and bivalent. And you're seeing that the dose schedule is, they're saying that 2 doses 6 to 12 months apart before the age of 14 years. And if it is more than 15, the catch-up can go till 26 and 45 as per Foxy says. 3 doses is what is the recommendation. In LMIC countries, now this is something which is really going to be of a help to us when IAP and Foxy comes up together, and with what Dr. Niranjan was just reiterating, that about on 10th of October when they came up with the white paper, and then that has been submitted. Definitely all these focus joint efforts is going to see that, by giving a high coverage, we can definitely avert more than 45 million deaths. And added to that, if you have a screening, fantastic. Furthermore, 14 million deaths can be averted as per this paper article. And then this was a Sweden study, and then they had shown why, what is the benefit of giving it at a younger age. And you can see the vaccines given below 17 years of the age. So the cervical cancer is really very low. And then if you have it staggered at 17 to 30, you can see a staggered and not vaccinated, you can see the peak going up. So that's exactly, and whenever you give an HPV vaccine, of course, you're also preventing the other cancers as well, which are related to HPV. Now, the key points, the practical points which people come to us and ask, Humne to bhai, first of all, the main question is, we have interrupted dose. So what should you do? So the interrupted dose ho gaya, to koi dikkat nahi na. Second and the final dose, you complete the course whenever you remembered, but then you have the duration. 15 months tak you can finish it off. Now the statements are also coming as per the WHO that you can, if you have forgotten before the age of 15 years, you can still have that, this thing, I'll show you that, this thing, presentation was slide, which has shown that suppose if you haven't taken the next dose before the age of 14 years, all right, the 2 doses 6 months apart, you can still take it up at 12 to 15 months. Max to max, you can take it till 5 years also. So single dose is also coming up. So these are the things which you have to know. We have to encourage our community to take it up, and as well as our people also to take up, the Foxy champions to take it up. Now, let me, we are very little premature to announce this, but definitely we are going to come up with a huge vaccination program across the country, and that's going to be a super hit. Watch for it, and we will require all your help as well for completing that. Now, another question comes is, agar maine, my child is taken bivalent or quadrivalent, and now the nonavalent has come up. Now, should I get revaccinated? So many calls comes up. So there's no need, because of the cross protection, and you do have this cross protection. So don't have to. Now, this was the SAGE recommendation, that flexibility, you can see, from 6 months to 3 to 5 years for the first dose. Now, 1 dose regimen is also coming up as per the WHO recommendation. Now, the next question is, okay, you are vaccinated. Is that enough? No. What is the impact value of a screening with vaccination? You can see the impact is 62% reduction, 65% reduction in a whenever there is at least twice in a lifetime. This is at least VIA, but imagine if you do it with an HPV, what steady impact it would be, along with Vaccination. What is the importance of screening? That is, you are doing it at the earliest before even the abnormal things have come up. This is very important. Why in our country it is really not taken up the way it has to, because now the joint efforts, government talking, Foxy talking, and our Foxians doing it together should really show this impact now. And then we do have the modalities. Again, whenever we talk about screening, everyone starts, ki bhai kya karna hai, scratching their head, what to do, I don't know. And then they forget it and I don't forget it. No, it's that lost interest. This should not happen. And we know that, the aim of screening is to reduce the mortality before even these things are coming up. And many problems with awareness, many problems with lack of where to go, how to go, whom to approach if there is screen positives. And rather than this, what is happening? They are taking the simplest route out is hysterectomy. Please, dear friends, let's see to it that screen positives go for a fantastic OPD-based procedures, daycare procedures, and save the uterus as well. Now, what is the more this thing is, look at that. This is from the South Indian study, and it is only 7.1%. Even we did a study from the oncology committee. We found screening was marginal. Only 12% had done the screening pan India. So screening has got its low resource setting to VI allied, high resource setting to HPV DNA, core test. Very high resource setting go about with all this, genotype, NKI67 and P16, IHC tumor marker, and all that can be taken up. Now, that is a screening cohort. Now we have another major cohort coming to us is a clinical diagnostic. There are unhealthy cervixes, most common cases, and each cervix has its own, story to say. So this is how we actually see cases. And we do want to know then how do you approach these as well. So screening to ek part ho gaya, but most of the time when we are actually dealing with these cases, how do we go about is one really important thing which we have to understand. And understanding the fact that it's a simple understanding. It's not a very major understanding. We know this, that there is either normal or cancers or precancerous condition. Now to understanding and also see to it that this is how actually I talk to my patients also, that persistent HPV hoga to hi aapko cancer ho raha hai na. Otherwise you are in the risk stratification. Let us see you, let us do your HPV, let us understand are you in the risk stratification, are you in the low risk, and high risk is the main thing which we are concerned about, 16-18 and non-16-18. And then there's understanding ki if you are there only this persistent, you can see this graph, and that shows cancer. And now this was one IPCO study which showed that normal cytology also has 5% 16-18. Low grade lesion on cytology has 28.2% 16-18. High grade has 62, and cervical cancerous it has 83. So we know this, that HPV can have this transformation. You are supposed to pick it up by various tests, and then you have to prevent it by doing management so that nobody goes into CINs. So paradigm shift has been there. Talking about cytology, we know that Bethesda has to be used, and cytology, we know this, that George Papanicolaou was the main person. I mean, we have to really respect these and honor these scientists who have brought this thing to our armamentarium. Then we have this conventional pap test, slide making. But believe me, honestly, dear friends, nowadays we, unless and until it's really a government setup and do not have the funds, then only this slide thing goes on. You can use a brush as well. And because we don't have to lose that 80% of the cells on, while making the slide. So use this, the brushes achhe hain, and it's so simple to use an LBC. You see, it's so simple. Ek brush ghuma diya, you have an endocervix, ectocervix, you have everything onto your, you put it up into the LBC, and then you don't have this inflammatory smears and all that. So that's simple. So when you know this, you can see pap smears, it's better to do an LBC. Where is the difference? The difference in sensitivity occurs in identifying low-grade lesions. So 12% better in identifying low-grade lesions. That's where your LBC comes into a play. But our major problem is inflammatory smear, the cloud hanging. We have a lot of challenges as well. It's a subjective test. One of the studies shows that 33% of cervical cancers had normal pap test. Then you have VIA. Now, VIA again is augmented with, with AI nowadays. So VI principle is whenever there is a high intracellular protein, there is a coagulation and then there is a obstruction of passage of light. Hence, you see this VI positive. 1 minute of application, it has to be freshly prepared, 3 to 5%. And you have to identify all these things when you apply for 1 minute and observe for 1 minute. And then you have VIA positive and VIA negative. So now these are VIA negatives where you do not have any acetovite areas. These are VIA positives where you have these acetovite areas. And these are overt cancers. And another thing is augmented. Now, many a times, these low-grade lesions are sometimes missed out. And that's exactly where AI comes to help. Now, see, this is an AI which is showing normal. Now, this is an AI which is showing abnormal. But then again, challenges. VI testing has got its own challenges, can't do it more than 50 years. And it has a subjective intervariability is there. Then comes up NAT test. Now your HPV test. Now, this is one of the best things. I mean, anybody walking into the clinic has to get her HPV done if she sits in that age group. This is some dictum which all the centers, 35 centers in our SNHC healthcare is practicing. Let it be from rural to urban. Now, that it is cost effective. People say it's not cost. Now, Dr. Sanjay Gupta sir's lab is getting a very good cost effective HPV. So these really helps, So no confusion, clear, high negative predictive value, a very good sensitive test, and hence it makes us understand. Now, the validated test, you should know which are the validated tests which is available, why an HPV is said, because you cannot take any RT-PCR. That's one thing, because we are not lab-oriented people. We are clinical-oriented people, and clinical sensitivity carries a major weightage because not every HPV is going to cause a reaction or a precancerous condition. Hence, have a good HPV test which has a limit of detection. And you see the single round of HPV, this was from Dr. Shankar Narayan's study, it had a significant reduction in the numbers of advanced cancers. And also when you see the cost effectiveness of utilizing, you can see the study from Tamil Nadu, which has shown that so many deaths and so many DALIs have been averted. So now we have this approach given by WHO, very clear, very straightforward, and understanding the sensitivity and specificity of each test has become really simple, Now, whenever you have this positive, you go for colposcopy as directed biopsy is the best option. I always call colposcopy as Shiva's third eye, as gynecologist's third eye, because it's hidden, right? You have to manifest it, you have to do it, you have to get those lesions out. And Hans Helsingman was a person who actually, a doctor who pioneered. And indications for colposcopy, screen positives, of course, you'll go for a colposcopy. Unhealthy cervix, go for colposcopy. Hyperkinetic patch, go for colposcopy. Risk stratification symptoms like postcoital bleeding, postmenopausal bleeding, intramenstrual bleeding, persistent white discharge, irrespective of your screen test, you please go for colposcopy. And these are the instruments. Your colposcopy tray has to be completed. The instruments has to be there. All the instruments, which are the basic requirements, has to be there. Few instruments we have patented out of this. One is our PGK automatic insulated tissue holding forceps, which has also come up in the yearbook. So now these are on colposcopy, you will very well easily identify, put a sweet scoring, you identify those lesions, and these are all histopathological identification. Whenever you do a colposcopy, take a nice good punch or take a leap biopsy whenever it is endocervical, and you come up with these results. Now, when you come up with these results, you put a diagrammatic representation, put a sweet scoring, give a fantastic reporting, then comes your case management. That's how you will prevent. ऐसे नहीं कि उसको दे दिया और उसको छोड़ दिया, नहीं. You have to now take her up onto your trend, onto your stride and say, look, dear, I can really help you. You don't have to go for a hysterectomy. Everything is curable. This is some confidence which you will have to give to the patient. Where fantastic ablative excisional techniques are there. And when you talk about thermal ablation, thermal ablation is really taking fantastic way forward for treatment, So you have 40 seconds. Nowadays, this thermoglide has come, which has 20 seconds applications. Do that, no requirement of a local anesthesia. Several times you can use it. These are thermoglide instruments which I use. And it's a very simple thing. You can see over here. I can just play this video for you. What it does is intracellular water is getting desiccated, and that's exactly how there's a denaturation of the cells and flowing out, and then the new cells comes up and it's normal. So that is and then tell the patient not to have contact for 3 weeks. You might have a blackish discharge. Now, I have shown you one case of thermal ablation. See this case. Now, see, these are all positives. And then we have done the thermal ablation. And look at this, completely healed. Then comes up cryo. Now, many people do cryo. Now, cryo, okay, it's a simple thing and it's an age-old thing. So you have this freeze, thaw, freeze. Wait for the thawing till the, it's a meta-analysis understanding. Wait for the frost to defrost, come back to the pink color, and then, apply it again. So how does it help? It helps by intracellular water gets crystallized. See over here. So here you have minus 68 degrees centigrade, and the periphery is minus 20 degrees centigrade. And it's so simple. It is the most simplest thing. Now, see, I brought one case of cryotherapy. So it's very simple. And does not require any great learning, anyone can learn little bit and paramedics can do it. Then comes LEAP excision. Now this requires a little bit of LETS, what we can call as, so what is understanding is LETS means you're doing an excision and treatment. LEAP normally are being interchanged, but LEAP usually we say it for biopsy. Principle is you use a blended current, blended cautery, monopolar cautery. And see, I'll just play a quick, I'll take you through. What we normally do is, we have to give local anesthesia. I'm using a spinal needle. You can use dental needle. You can use anything, but you give a nice copious 20 ml I normally give. And then you have this technique of spray technique. This technique is there. You go very slow. And then the desiccation current, fulguration current, not desiccation. So fulguration current is used, fulguration technique. That is what? Giving a short window. Go very slow. This is a copped up video, but otherwise I take 15 minutes for a fantastic LEAP. Take it out, and then you can take a ball cautery, completely cure it. And then when will you call her up for follow-up? You will call her up after, say, 6 months to do a relook colposcopy, and then after 1 year for doing a test of cure with HPV. Say this one case. Now here we have done a LEAP. Here I've taken, so LEAP, normally you give side to side or from down to up. You don't go up to down. ऊपर से नीचे नहीं जाते हैं, and then this is post-LEAP follow-up. So these are, now WHO has come up with a fantastic understanding of screen, treat and screen, triage and treat. Now in screen and treat, they have used VIA देखो, screen treat करो, या HPV देखो. Now this is little bit more, what you can call aggressive. That HPV देखो, apply an SCJ, apply acetic acid, identify the SCJ and apply the treatment. So that's exactly screen and treat. So HPV positive hai to aap jaiye treatment ke liye. Then there is screen, triage and treat with various methods. Now, if you have to understand this, I will quickly take you through. VIA karna hai, positive hai, check up the criteria and treat. So here, see, I've done this. I have checked the criteria, but here I have gone ahead by doing a LETS, because here, otherwise this was going so deep inside, and so much of endocervix is also involved. Hence, I went ahead and I said, it's like, doing a LETS is better. Then this is a post follow-up. She comes after 6 months. Then other case, I'm showing HPV positive ho to aap kya karoge? See, one of the case, 34-year-old, menorrhagia hai, fibroids hai, she is HPV 16 positive. And what I do is I straight away take a nice larger LETS and I do a LETS for her. And this case came up to be a query, invasion some places and HSIL. So she had no complaints whatsoever with the cervical related. It was only menorrhagia, multiple fibroids. And she did a second evaluation with Dr. Borges. And then they said, yes, it is HSILV 16 positive IHC. And then she comes up to after 6 months, and you can see healing blood vessel pattern. These are normal healing blood vessel pattern. When I purposely take a biopsy just to be in more this thing, it is showing as regenerative, nothing to worry. And test of cure again is normal. This is the way you take it up. You can take up cases. Now another, see, cytology. We all do cytology. So cytology may ask us hoga. So what will you do? Put an HPV test and identify. If it is HPV positive, go for colposcopy, treat it. If it is more than ascus, like see, I got one case from Dhirubhai Ambani, from where that Ambani hospital. Now, this was for an HCV positive liver transplant. Uska un logon ne pap test kiya. So that was HSIL. And then they sent the patient to me and I did a colposcopy. I've done a biopsy. It is carcinoma in situ, cervical dysplasia. And of course, then the management goes accordingly. And then I can tell you about, so definitely surgery was planned for her before the liver transplant. Then comes, suppose you're doing an HPV DNA, you can reflex the same test with a genotype. Now let's understand the genotypic way of taking forward. Like HPV DNA hai, aapka positive aaya, you have done, it was 16, 18, then you're going ahead treating. If it is non-16 and 18, aapne VIA triage kiya, you have identified whether there is a lesion or anything and then gone ahead. Like suppose if this, I'm taking one case, okay, now this, I was an HOD in one of the largest screening program of the country. Now I have come out of the job. Now in that, one of the lady came up asymptomatic, uska hybrid capture kiya, that was positive. She was then triaged with 16, HPV 16, she was 16 positive. Look at that. And then when she came up to us, this is the thing. And what I did was simple. Na, uska ek achhi tarah se let's kar le. And let's also show SIN2, SIN1. Absolutely nothing. You know, she was mRNA positive also because it was a high resource area. So we had all the things with us, you know, IHC tumor marker, mRNA. But these are the cases, you know, they just walk in and they do have all that. And then after 1 year, she's negative. It's very important to screen. That's very, very important. And to keep up and to follow up. That's more important than, along with screening. Keep up for 20-year surveillance. That's very, very important because anytime again, they can, you know, have a recurrence of this. So it's always better tell her, do not become over-complex. Treat ho gaya, khatam. No, they have to come back to you. You have to keep them under surveillance. That's very important. Now, again, if you do an HPV DNA and if that comes positive, see, many people do not have colposcope, but that cannot be a lame excuse. Aapne HPV kiya, you have done a 16, 18, 18 is positive. You can apply VIA, no? Why have a lame excuse कि मेरे पास colposcopy नहीं है तो मैं नहीं करेगा? No, it's not like that. Do a VIA. You can see this dense area. We took a biopsy and that was like infiltrating cervix. Squamous cell carcinoma. Now we had to refer this case. Or that's exactly how you do. Then you have another one. Now you have a colposcope. Then also it's simple. Aapne HPV kiya, 18 has come positive. All right. And what did you do with her? You did a colposcopy. In a colposcopy, you understood that this lesion is going endocervix. So definitely the treatment then goes is according to your this thing, you know, endocervix to do a LETS. And that's how we did a LETS. And the LETS biopsy had shown SIN2. So, so follow-up then again becomes after 1 year, we saw that HPV had gone away and then she had become treated. Now she's under surveillance. That's very important. The last one, HPV kiya hai, cytology kiya apne, and if it is more than ascus, you go for this thing. So colposcopy guide. Now see 32-year-old, she comes with repeated postcoital bleeding. She's 16 positive. And look at this, okay? She's 16 positive and you have done an pap test and she's as sketch. We had done a colposcopy on her. And then we did a biopsy because here I had a suspicion. That's why you cannot treat her. Here I had a suspicion this is a cancerous condition. So we waited for the biopsy report and then took up so it's carcinoma in situ, some places, invasion also. So, dear friends, now what is the prerequisite for all these things? It should be affordable. See, whenever you take a case, it should be an affordable, it should be reproducible, it should be quantifiable, it should be less cumbersome, it should be less observer variability, expertise should be available, longer recall period, good sensitivity with low false negatives, good specificity with low false positives. And hence, I always love to say that, you know, and this is exactly where, you know, Ralph Emerson came out with a wonderful quote, which I like to reiterate every now and then, that do not go where the path may lead, go where there is no path, leave a trial behind, do the things which are right to be done. No, SNSC has been, the efforts has been really now showing hands with so many of the centers happily coming to take up these, you know, the centers and this thing. So we have all this, you know, books are there. Everything is there. It's only that you have to come, take it and, you know, sort of start doing it. Many courses are available. IHCP courses are available. WHO courses are available. SNSC courses are available. Foxy courses are available. Dr. Niranjan Chavan, I remember during his you know, the committee chair, he had made so many doctors, even I was one amongst them, for my center to get accredited. So that was Dr. Chavan who had done that. So see, that's very important. Courses are there. It is up to us to take it up. And, medical officers, MP governments, J&K governments, everybody are now really, really taking a stride into making their MOs, paramedics, learn, come up. These are very important. These are what I did it for MP government. Then the courses are all there. See, there is no dearth of course. Now our course calendar is also there. Anybody, we have so many people, doing these courses. So it's not a dead end, dear friends. There is an alternative ending. And I would like to say this, and I love this thing. Focus your energy. Without focus, your efforts will have little impact. Focus on building new systems, not fighting the old ones. Shape not only your future, but the future of those around you. And I love to again say that when you say focus, sometimes it becomes perplexed. Kitna dekhna? Nahi. Go for step by step. Focus on the steps in front of you and not the whole staircase. And once you take up properly, I am sure, why not India will not see a cancer mukta Bharat? It will see. And I like to end my deliberation by saying that valuables we carry may impress others, but the values which we hold will truly inspire others. So thank you very much for your patient hearing.
Thank you. Thank you so much, Dr. Priya. It was really, I don't know, because in MP, you are our teacher for all of us, all our medical officers, all our paramedics. Actually, we are getting it done, and we have a group here on WhatsApp also.
I know.
From the CMHO office. Every day they have to give a reporting. So the screening will really, your efforts will see the dawn, because it has really come up, and now every person knows what is VIA, what is PAPS, and what is HPV. So I hope this your approach was very true. But only thing I was going to ask you was that you said follow-up for 20 years. Suppose one person gets an HPV positive and she goes into VIA, everything is negative, it's okay. And you said no hysterectomy for her, no fear factor for her. Then when should we call her again for if she's once
now
positive?
The WHO says abhi kya hua hai, GCPR said call her up after 1 year. Jo HPV positive hai, call her up for 1 year. But now the latest understanding is it takes almost 2 years for the HPV to wipe off, wash away.
Oh, okay.
That's the reason, call her up after 2 years. That's much better, Yeah, that's also WHO things also. Yeah.
So in that meantime, she doesn't have to get anything to be done.
You've already done a triage, right?
Okay.
You've seen that there is no lesion. So why should you worry about?
Okay, that fear, that psychosis,
that's exactly where, Palm, we are all, we should be the mouthpiece now, we should be the advocates, counselors.
Yes. Yeah. Now, listening to you, I can advocate now, because even I used to feel after 2 years, if she lands up here, then she will be after my throat. Madam, aapne ka kuch nahi.
Yahi to dar lagta hai, mera gala phas gaya to main kya karu? No, it's not like that. You have science based on it.
Thank you so much. Really, really, always a pleasure to listen to you. Thank you, Priya. Thank you so much.
Thank you.
And Dr. Mamta, you want to say something?
Yeah, thank you, Dr. Priya. So thanks for the nice presentation, though I missed a part of it. I had to just log out and then I logged in again. And I know it was my loss, but thank you so much. And as said, it's a pleasure to listen to you always.
Yes.
Thank you.
Thank you, Dr. Priya. I think it was very, very focused, crisp, and so much messages we got, There's so many things which we think when to do, what to do, how to go about monitoring, follow up, everything. I think it was really, really very good. Thank you.
Thank you.
Thank you, ma'am. Thank you all for such an exhaustive coverage. I thank Dr. Shashibala madam and Mamta ma'am for sharing this session, and Dr. Priya ma'am for delivering such a academic feast. We now move forward for the next session. Can I have the CV of the chairpersons, please? Our chairpersons for the next section is none other than Dr. Pinaka Vamsi. He is an associate professor at Homi Bhabha Cancer Hospital and Research Center at Visakhapatnam. He is currently the secretary of ISCCT. We have our next chairperson and Dr. Nikhil Parvate. He is a senior consultant, a gynec oncologist, head of the robotic surgery services, head of colposcopy services at Aditya Birla Hospital, Chinchwad, Pune. He is also the Foxy approved trainer for colposcopy. It is great pleasure to have both of you here. I request Dr. Vamsi sir to please introduce our next speaker. Vamsi sir, you are on mute. Vamsi sir, can you please unmute and speak? Nikhil sir, are you there?
I saw Dr. Nikhil, he's there. Both are there.
Both of them are there. I'll just give a call to. In the meantime, can you please?
Yeah, Dr. Nikhil is here. Dr. Nikhil is here.
Hello, Dr. Monika. Yeah, I've just come. Yeah.
Sir, can you please introduce our next speaker, sir?
Yeah. Good evening, everyone. Thank you for giving me this opportunity. It's a pleasure to introduce Dr. Manoranjan Mahapatra. He's an obstetrician and gynecologist at Mahapatra Hospital, Cuttack, having expertise in advanced laparoscopic surgeries, secretary of the Gynecologist Association, awardee for Kalinga Ratna and Naba Ratna Award. And we would like to hear more from him about treatment, advances in treatment and management of CA cervix. Over to you, Dr. Mahapatra.
So is my slide visible?
Not it, sir.
Just a minute. I hope now it is visible.
Yes, sir. Yes, sir. Can you please make it on full screen, sir?
So esteemed chairpersons, am I audible?
Yes, sir.
Yes, sir. Yes, sir. Please go ahead.
Hello.
Yes, sir.
Thank you. Thank you. So esteemed chairpersons, the esteemed convener of this meeting, the organizers and respected faculties in the meeting, Galaxy meeting, Dr. Gupta, Dr. Niranjan, Dr. Neerja madam, and other Galaxy of the gynecologists and of course persons from the oncogynecology. Well, the topic assigned to me is advances in management of cervical cancer. My CV is updated actually. I am associate professor in RCC, HPGIC Cuttack. So it was conveyed to me 48 hours before that I will be presenting in this webinar. So slides are made a bit hurried. However, from my experience and from the practice, I'll try to make justice to this topic. And my job will be to ventilate the few of the very practical guidelines to the fellow gynecologists present in this webinar. Well, when we talk of these advances in the management of cancer cervix, just I am presenting a case scenario here before I start this seminar, this presentation. She is a 42 years para 2, both vaginal delivery, presents with postcoital bleeding for last 3 months. On perspeculum examination, exophytic growth in ectocervix, which bleeds in touch and it was friable. And on PV and PR examination, the growth was 3 centimeter and the left parametrium was resistant. So that was the case in clinical scenario. And here I'll ventilate few of the key points to my fellow gynecologists that from this case story, few things we should not miss. That what are the symptoms that a patient is presenting to us? Because she is suffering for last 3 months. She might have visited few of the gynecologists, but somehow she has missed. So the symptoms, most important symptoms I want to ventilate is the post-menopausal bleeding. Any patient who has a complaint of post-menopausal bleeding, we must not forget to put a speculum in the vagina. Whatever may be our busy schedule, but we must not forget to put a speculum in the vagina. That's the first key ventilation of the message I want to ventilate. Second, a post-menopausal abnormal vaginal discharge. If somebody is complaining that I'm having profuse discharge or foul-smelling vaginal discharge, please examine the patient and try to put the speculum in the vagina and try to examine the cervix. That's the first and foremost and the simplest thing that we can do as a gynecologist for this post-menopausal lady. Any patients who are premenopausal or perimenopausal, they are complaining that I am having postcoital bleeding. Never miss to put the speculum. And somebody who is complaining that I am having bleeding in between the menses or on and often, then always examine for speculum. This is the standard teaching that we used to teach. We have been taught, but in busy schedule, many of us used to forget, and ultimately lesion used to progress. So that is one thing. So the symptoms never to forget is the abnormal vaginal bleeding and abnormal vaginal discharge, particularly foul-smelling discharge. Then in the signs, while examining the patient in the first speculum examination, obviously as Dr. Priya told the different things about the pre-invasive lesion, and of course in the early lesion also it is applicable. The surface lesion, if the cervix is looking unhealthy, then we can go for the acetic acid test or the Lugol's iodine test, and we can go for the targeted biopsy or colposcopic examination for the early lesions. But when there is obvious growth is there, then the key features of the growth is bleeds untouched. It's a very important features of a malignant tissue. Whenever we will bleed, we will touch the tissue, it will start bleeding because of the friability of the tissue and because of the neoangiogenesis. Then second is the friability of the tissue. Once we hold the tissue, it will come out. So bleeds in touch and friability are the two important things that we will find in that tissue. So these are the two things to remember. Then when we will do the PB combined with the PR examination. So PR examination, if you are suspecting a case of CA cervix, is an integral part and necessary part of the examination. If you are not doing PR examination, then probably we have not completed our clinical examination. So the purpose of doing the PB and PR examination is to assess the growth size, to assess the parametrium clinically, and assess the fixicity of the growth if it is a larger growth. So the assessment of the parametrium has to be done, and whether the parametrium is free or there is some induration is there, or if the growth is a larger one and advanced one, then there will be some fixicity to the lateral pelvic wall. So there are two key important signs will be there. One is friability, one is the induration, another is fixicity. It's for the advancement of the lesion. So in the signs, the bleeds in touch, friability in early lesion, and of course, when there will be advanced lesion, the induration and the fixicity will be there. So these are the few important things. These are standard and that we should remember. Then when the growth is obvious, then we should take the biopsy. How will we take the biopsy? Usually we take the OPD based biopsy. The punch biopsy is the good method if obvious growth is there. If obvious growth is not there, then we can take a target biopsy, of course with the VIA or the Lugol's iodine based, and target biopsy we can take by the wedge biopsy or the cone biopsy or the lip, but our purpose is to take the tissue, affected tissue, and subject it to for the biopsy assay. Again, to talk about the biopsy, we must send the tissue. the proper level tissue to the defined, who are acquainted with commenting regarding the oncopathology. So we should send the tissue for the analysis and reporting to that laboratory. Then most important is the analysis of the biopsy. What is the report? And we should not miss the report to read. And once the report comes, the report is a squamous cell carcinoma or the adenocarcinoma. And what is the differentiation, what is the keratinization? These are some of the added things are there, which hardly has an implication towards the management. So next, with this case, what to do next? And first, in what to do next, the first thing comes in the mind for the cervical cancer is what is its stage. With that only, whole the scenario, whole the management system will revolve. What is its clinical stage? Is that the answer is correct, or is that the answer is sufficient? Dr. Neerja madam and others has changed the game in 2018, and they have proposed a new system, and the staging system changed. And earlier what was there, purely a clinical staging. Now the imaging and the pathological aspect has been added, and some of the staging has been changed. The A1, A2 has changed. Again, the B1, B2, which was there, it has been divided into 3, B1, B2, and B3. Then other 3, C1, C2, and other things which are changed is in this slide. I am not going in details. Everybody can get this in the Google, and everybody can have this. And once you will find it with the clinical parameters, with the biopsy proven a case, then what you will do next. So new FIGO staging for cervical cancer launched in 2018 encompasses the clinical, pathological, and imaging system for the staging purpose. This is one new advancement. So lymph node was not part of the FIGO staging before 2018. Now they are an incorporated part. Stage 1B is now divided into 3 parts, as I have told. So to define now the lesion and the lymph node status, the imaging has to be done. MRI pelvis is an important tool to evaluate the parametrium, particularly the 1B lesion, where the parametrium is not involved clinically, and pelvic lymph node status should be assessed by the MRI, and this should be confirmed. Then ISC is an important tool which play an important role in differentiating the endocervical from the endometrial carcinoma with endocervical extension. The endocervical carcinoma will have usually P16, Ki67 positive and ERPR negative one. In endometrial carcinoma, usually ERPR positive and P16, Ki67 negative will be there. So this is one region in which we can define with the ISC. So the concept evolved around a single line statement is that the therapy is a designed monomodal therapy. I repeat, a monomodal therapy. So our planning should be like that. The patient should get only one mode of treatment. What are those mode of treatment we are with? One is surgical mode of treatment. Another is radiation mode of therapy. So radiotherapy and sandwich with some chemotherapy or chemotherapy in advanced cases. So whatever mode of the therapy we choose, it should be one mode of therapy. That is a more important message. Not that we are surgeons, we'll operate and we'll send for the radiotherapy. No. So pre-operative planning is the most important thing that we must know and we must do it. So dual modality of management to be avoided as it increases toxicity without any survival benefit. So either surgery or primary chemoradiotherapy to be done, but not both. So this sentence is very much important for the practice guideline. So before surgery, patients should be selected in such a way that they should not receive any post-operative adjuvant treatment. So that is the most important thing. That's why we must pay attention to clinically stage the disease, and we must evaluate through the imaging. Then only we should select for the proper surgical method. The primary surgery is feasible in stage 1A1 to 2A1, except 1B3, that is for the more than 4 centimeter lesion. Then primary chemoradiation is the treatment of choice in stage 1B3, stage 2A2, and stage up to stage 4A. So regarding surgery, the principle of surgical treatment is the radical surgery. But again, I will say the advancement what has been done or what has happened in recent time is the oncofertility is a separate branch now, which is evolving. So in any case, when we are offering treatment, the oncofertility or the fertility issue and the conservation of the uterus issue comes to us, and we must discuss with the patient before offering the basket of treatment. So that is an important thing. Accordingly, we should plan, and our planning should evolve. So lymph node assessment should be performed as the first step of the surgical management, as if there will be lymph node positive will be there, or enlarged lymph node will be there clinically, or metastatic lymph node will be there, then the case should be abandoned and it should be subjected for the radiotherapy. If at all we have misjudged, it's in pre-surgical stage. Then intraoperative assessment of the lymph node status by the frozen section is again an advancement. The standard lymph node staging procedure is systematic pelvic lymphadenectomy. If we don't have the facility of the frozen section, if our institute is not standardized for the sentinel node, then the lymph node staging procedure is always a systematic pelvic lymphadenectomy. The systematic pelvic lymphadenectomy encompasses 5 groups of the lymphadenectomy. What we usually practice is the external iliac group of the lymph nodes, lower and upper group, the common iliac group of the lymph nodes, the obturator group of the lymph nodes, and the internal iliac group of the lymph nodes. Presacral group of the lymph nodes, usually we don't practice because that drains mostly the posterior aspect. So these are the 5 groups of the lymph nodes which are retrieved in the both sides. So there is no concept of the unilateral lymphadenectomy in the management of the cancer cervix. Sentinel biopsy before pelvic lymphadenectomy can be an option in centers where sentinel lymph node procedure is validated only. If you have no validation, then you can do it on trial basis. If it is in the trial, combination of the blue dye with radiocolloid or use of ICG is the recommended technique. All sentinel nodes from both sides of the pelvis or any suspicious lymph nodes should be sent for the frozen section. If sentinel node is not detected, if there is no facility for the sentinel lymph node, then bilateral complete pelvic lymphadenectomy to be done as I have told. The lymph node to be sent for frozen section. If it comes to be negative, then proceed for radical hysterectomy. But if lymph node comes to be positive in frozen section, then operation to be abandoned and patient should be planned for the primary chemoradiotherapy, as I have told earlier also. Because there is no need of going for the full-fledged radical hysterectomy and pelvic lymphadenectomy. Already one node is positive. I will come why we should not do. The type of radical hysterectomy should be based on preoperative staging. Ovarian preservation should be offered to premenopausal patients with squamous cell carcinoma and HPV-related adenocarcinoma. Bilateral salpingectomy should be considered in those. But young patients with non-HPV-related adenocarcinoma should be counseled carefully regarding BSO due to the high risk of metastasis and relapses in the adenocarcinoma compared to the squamous cell histology. These are some of the guidelines are there. Then we can go to the guidelines. We can find after counseling with the patient, with the stage and all, as I have told. Then regarding the treatment, earlier what was there is going for the radical hysterectomy straightforward. Now it is a tailor-made treatment, not a ready-made treatment. As per the stage of the disease, as per the requirement of the patient, then we have to make it tailor-made that what should be the mode of the treatment. The mode of the treatment available to us is the conization. Number 2 is the trachelectomy, radical trachelectomy with the pelvic lymphadenectomy, then conventional radical hysterectomy with the bilateral pelvic lymphadenectomy, radical hysterectomy plus sentinel lymph node biopsy plus frozen section. So there are basket of all the different modalities of the treatment now available, and those are some of the advances that we must be aware of. So stage 1A1 for the small lesion, the conization is an acceptable treatment for stage A1 squamous cell and adenocarcinoma of the cervix. Reconization is recommended if the specimen cannot be oriented, which is important. Once you will do the conization, you must mark which part and which side it is, and that is most important for the pathology for the surgeon. Otherwise, the orientation will be lost. And if the tissue is fragmented and has dithermy effect, then makes margin assessment impossible, then reconization is necessary. That's why the loop treatment or loop should be ideally avoided. It should be done with the cold knife, particularly to assess the margin. Conization for the cervical cancer is often large and multiple and carries a high risk of obstetric complication in the future. This must be explained to patients who have this treatment and alternative option discussed. So that's why counseling plays an important role. These are few of the guidelines are there. I am not going into the detail. Then 1A2, again, patient desirous of the fertility without LVSI, conization or the simple trachelectomy. With positive LVSI, conization or the radical trachelectomy with sentinel node biopsy or the pelvic lymphadenectomy. If patient not desirous of the fertility, then simple hysterectomy with sentinel node biopsy or the pelvic lymph node dissections. Then these are different guidelines are there. I'm not talking of the very new things. Everybody can Google it and find it in the NCCN guidelines. Then stage 1B1, here, if patient is desirous of fertility, then radical trachelectomy with sentinel lymph node biopsy or the lymphadenectomy is considered. If she is not, then we can go for the, again, an important advancement is the C1 or the nerve sparing radical hysterectomy, and we can go for the bilateral salpingectomy with bilateral pelvic lymphadenectomy, and ovarian conservation may be considered if the patient is young. And we can fix the ovary, we can transfix the ovary to the abdominal wall in the higher up position so that it will not be exposed to the radiation. Then in 1B2 and stage 2A1, no fertility preservation option because they are a bit advanced lesion, and standard treatment of the conventional radical hysterectomy, either type C1 or C2 preferably, is the most preferred one, because the nerve conservation, if you are conserving, then radicality will be compromised. And bilateral salpingectomy with the lymphadenectomy with or without removal of the ovary as per the age. Then 1B3 to the stage 4A is there is no role of surgery, because if you are going with the large lesion, especially I'm talking of the 1B3, then we are going with one risk, that is the more than 2 centimeter lesion. And obviously they used to more than 95%, they used to have the LVSI. So already 2 risk factors, intermediate risk factors we are going with. So that suffice for the adjuvant radiotherapy. That's why those lesions are not to be done for the upfront surgery. The treatment strategy is going for the radiotherapy. So definitive platinum-based chemoradiotherapy and brachytherapy is preferred. So those are the lesion. The radiotherapy is the treatment of choice, and of course for the stage 4B lesion where there is distant metastasis, the chemotherapy is the treatment of choice, and radiotherapy can be given to control local intractable bleeding if the patient is bleeding. So adjuvant treatment post-surgery, there are high-risk factors are there. If there is positive pelvic lymph nodes or the parietic lymph nodes, parametrium spread, there is parametrium is positive. If positive surgical margin, the vaginal margin is positive, then those are the, even if the single factor is there, then we should subject her for the adjuvant therapy. If there is intermediate risk factors, if there is presence of the LVSI, tumor is more than 4 centimeter, there is deep cervical invasion, then if 2 factors are there, then we can go for the adjuvant therapy. So there are standard guidelines are there. We should follow that. Most important, not only doing surgery, but in oncology, our story starts from the surgery. In benign surgery, our story ends there. But in oncological practice, our story starts from there only. That is the basic concept that we must conceive. Then regarding definitive chemotherapy and brachytherapy, overall treatment time is around 7 to 8 weeks. Overall treatment for the external, there are 2 modes of the radiotherapy. One is given from the distance, that is the teletherapy or the external therapy, radiotherapy, and one is given inside the body, that is called the brachytherapy. This teletherapy or the external beam radiotherapy, conventionally it was given earlier by the cobalt machine with a cobalt source, radioactive source. Nowadays, the advancement is that it is now given with the linear accelerator, in which the electrons are bombarded and there is high amount of the kinetic energy is produced, and that is very much specifically targeted to the tissue, and that energy damages the cancer cells. A lot of advancement has occurred in the radiotherapy aspect. One is IGRT, that is image guided radiotherapy. Another is IMRT, that is intensity modulated radiotherapy. By that, very specific radiotherapy is subjected to the tissue, and thereby the side effects are very less, and we give equal justice and comfort to the patients as per the surgery. That's why a lot of studies have come that if we are not giving justice through the surgery, now it is very safe to give for the radiotherapy. Again, VMAT, volumetric arc techniques. So a lot of techniques are there with the radiotherapy that has evolved in recent time, and by that very specific radiotherapy is delivered to the tissue. Earlier with the cobalt machines, still we have one cobalt machine for LINAC. So in the cobalt machine, the patient used to have a lot of side effects with the skin, the cystitis, proctitis, very inflamed vagina, the thigh, inner side of the thigh, and after some time there will be a lot of fibrosis in the vagina. So she will have an almost miserable life. She will survive, but there will be miserable quality of the life. Now it has changed with the LINAC. The things has changed a lot. So whenever we are offering a patient which come to us, if there is advanced cancer cervix, we must offer her for the LINAC therapy, and particularly IGRT and IMRT therapy. So a total dose of 45 to 50 gray is there. Those are some of the deep details. Then tumor and lymph node related target volume for IMRT includes the primary cervical tumor. These are all of the details. I'm not going, but whatever I'm ventilating is the sum of the capsular knowledge for all of you. Then boost treatment for the involved lymph nodes can be given in very specific way by the IMRT. Then single agent radiosensitizing chemotherapy, preferably cisplatin, weekly 40 milligram per meter square is used unless it is contraindicated, and this boosts the radiotherapy effect, and that's why the treatment modality is CCRT, that is concurrent chemoradiotherapy instead of radiotherapy. Coming to the brachytherapy, lot of development has occurred in the brachytherapy. Gone are the days in which the needles with the radioactive elements were inserted into the vagina with the bare hand, but now completely afterloading technique with the machines. Then again, there is advancement that image guided adapted brachytherapy is now is recommended. Then previously used point based brachytherapy like point A and point B that we have learned in our postgraduate days. These are some of the recent advances that has occurred in the brachytherapy. And brachytherapy applicators should consist of uterine tandem and vaginal ovaries. All these things are the standard teaching and standard things. Regarding recurrence, it has to be histologically proven after 6 months of the completion of the therapy that there is the cancer tissue is there, and PET CT to be done to detect the distant metastasis. Only in the central pelvic recurrence, previously treated surgery alone, concurrent chemoradiation, and previously treated with chemoradiation, pelvic augmentation is the treatment of choice. And only lateral pelvic wall recurrence, then we can, again, if it is treated earlier with the surgery, we can go for the CCRT now. If there is CCRT given, then we can go for the laterally extended endopelvic resection. That is the layer technique, which is also an advancement. Then for the distant metastasis with or without pelvic recurrence, palliative chemotherapy, and of course the new advancement is the immunotherapy, and the pembrolizumab is the drug which is now in use for the recurrence. Then some of the recent advances that I was spelling out is the nerve sparing procedure. That's why the type C radical hysterectomy is divided into C1 and C2. And by doing type C1 hysterectomy, we are giving much of the comfort to the patients, just sparing the nerve to the bladder and the rectum. We are cutting only the uterine branch or the cervical branch. Thereby, the post-op life will be a better one. Otherwise, there are a lot of bladder problem used to occur in the conventional type C2 hysterectomy. Some of the guidelines, some of the instructions that what are the where we should cut the parametrium. Different parametrium have been defined. The lateral parametrium, ventral parametrium, dorsal parametrium, where we should excise in which type of the radical hysterectomy. It is clearly defined now. That is an advancement that we should follow as a surgeon if you are doing the radical hysterectomy. Regarding MIS, minimal invasive surgery, laparoscopy in the radical hysterectomy, a lot of the debates in the last 5 years, that has been a hot topic of discussion everywhere, that and it was a great back foot for all the laparoscopists like us. And however, we cannot do now the laparoscopic hysterectomy even if our fingers are reaching too much. But because the guidelines are restricting, but however, there are some of the trials are going on for the robotic surgery. If the result which is expected to come in 2026 will be a favorable one, then it will be an opening door for the laparoscopist also. So to summarize my talk, if we are having a patient with some of the symptoms like postmenopausal bleeding or the postcoital bleeding or the intermenstrual bleeding, then we should examine her. If there is a pathology, we should do the biopsy, and the clinically, if there is the growth is friable, if there is bleeds untouched, that suffices almost, unless it is proved otherwise, that is a case of cancer cervix. We should take biopsy and we should stage the disease clinically simultaneously. Then we should go for the imaging analysis and treat accordingly with the imaging. After the HP proved, then we can design our therapy, and the concept is monomodal therapy, and surgery is to be customized according to the stage, fertility desire to preserve the uterus, again I'm telling, and these are to be considered and counseled with the patient. Accordingly, the consent has to be taken. Talking of the radiotherapy, CCRT with LINAC, with IGRT and IMRT are the advancement, and it has to be sufficed with the brachytherapy with its own advancement. PET CT is an option to evaluate the distant metastasis, but it should not be a tool for the staging purpose or the upfront evaluation purpose. So unnecessary PET CT should not be done for a case of cancer cervix once the lesion is confined. So palliative care is an integral modality of the treatment. We should not forget as an oncologist, because the patients which are cured or not cured are with us, and there should be given an option for the palliative therapy. So if we talk of the advancement, then we should analyze all these photographs from the era of the 18th century down to this 21st century, then only we can evaluate what is the advancement. If I'll say today what is the advancement, then I have to encompass the history to prove that we have advanced. So these are some of the great giants in the field of the cancer cervix treatment. So we should give salute to them. And with that, I end my talk. Thank you, everyone. So the mic is over to you, madam.
Thank you. Thank you so much, sir, for this elaborate talk. And now I request Nikhil, sir, to kindly give the conclusive remark.
Thank you, Dr. Mahapatra. It was a very crisp talk. I think few points which you have highlighted is very well taken, because how an oncologist thinks and how a gynecologist thinks about the same CA cervix is quite different. Thank you for highlighting the point that stage-based treatment, need for frozen section. You have highlighted frozen. So, I mean, in big cities, one tier, second tier cities, I think people cannot say we don't have facility for frozen. So there's a need for frozen. And most important, need to abandon the surgery, because I see a lot of craze that once you have started a CA cervix, whatever it is, operate and get it out. No. So abandoning the surgery is very important. That's a very good point that you have mentioned. Third, that staging. Only, sir, I would like to add that as far as the staging, which Neerja madam has been a part of it, the stage 3C1, 3C2 have R and P in it, the small r and small p, where the lymph nodes are either proved radiologically, that is R, or pathologically, P, by a lymph node by either a pre-operative biopsy or intra-op biopsies. So somewhere down the line, that is the little fallacy of staging, where centers which have cancer centers are then bound to do a PET-CT, because most of the cancer centers have PET-CT. Yes. So it is that area that we are still not clear. So that is a little lacuna in the staging, because what is happening in our tumor board is we have to do PET-CT for all our patients, because only that will pick up that R of the 3C1 and 3C2 stage.
Yes.
And I'm very happy, sir. And second thing, what I wanted to add is that monotherapy for CA cervix is restricted to stage 1. So if it is a stage 1 patient, whether it is 1A, 1A2, 1B1, 1B, it is only one system of treatment. Either you do surgery, yes, after which they should not undergo radiation and chemo, or you directly send for chemo radiation. And again, there is a small fallacy which which I don't know whether Neerja madam is there. Again, one little problem there is, if we are doing 1A1, 1A2 and 2A1, 1B1, what happens is, if the cervical, what they have said is, if the cervical stromal involvement is even greater than 20 or 30%, they fluctuate. So what the radiation oncologist at our center tells, that oncologists should stop operating on CA cervix because of this fallacy. Because again, in stage 1, you will be doing the surgery, and then in the final histopathology report, if you get cervical stromal involvement greater than 30-40%, you will again send it for radiation. And you cannot find a cervical stromal involvement pre-op, either by a PET-CT, also even on the biopsy specimen. So these are little fallacies, and okay, we all have to work around in this tumor board. Thank you, Dr. Mahapatra, for an excellent presentation.
Thank you. Thank you very much for your supplements.
Thank you. Thank you so much, Nikhil, sir, for this great input. And thank you, Mahapatra, sir, for this brilliant talk. So
thank you, madam, and thank you all the galaxy of the gynecologists.
So now we can move to next session, that is a panel discussion on Caesarean. And we all know, although Caesarean one of the most routinely performed operation, but at times we are stuck. And of course, the technique matters, and also anticipation to the complication matters. So to deal these intricacies and to discuss these things, we have two ACE moderators and galaxy of panelists. And I'm going to the quick introduction of the our esteemed moderators and panelists. Our first moderator is Komal Chaman ma'am. We all know her, and she is doing tremendous work, be it awareness or arranging webinars or conducting CMEs or publishing books or doing research work. Ma'am is doing great work, and we all are much impressed, ma'am. Do continue your work, and of course we can achieve much better health for Indian women. So welcome you, ma'am. And our next moderator is Niranjan Chavan, sir. And we all know, sir is one of the most active office bearer of Foxy. We all know him, and currently he is holding two very important posts. One is Joint Treasurer at Foxy, and second is he's president of Mumbai OBGYN Society. And he's busy in the at both the places. We all see him busy at one places or other places. And sir has done many. Sir is currently the editor-in-chief of many prestigious journal, and he is on editorial board of European Journal of Gynecology Oncology. So he's active on academic front also, and sir has organized many course. He's course coordinator for 3 batches of advanced minimal access gynec surgery, and he has done many publication in international and national journal. So I welcome my the moderators of both the moderators of the panel discussion, and we can go through the quick introduction of all the esteemed panelists. So our first panelist is Rekha Rajendra Kumar ma'am. Ma'am is Medical Director, Miracle IVF Hospital and Chandana Hospital, Bangalore. And currently she is Vice President of Bangalore OBGYN Society during 2022 and 23, and past Honorary Secretary, BSOG. And she is a South Zone Coordinator, Foxy Infertility Committee. And she has done many publication and paper presentation in various journals and various conferences. So I welcome you, ma'am.
Thank you, Kanchan.
Our next panelist is Kiran Pandey, ma'am. Ma'am is a professor and ex-HOD at the Department of OBGYN, GSVM Kanpur. And currently she is the chairperson, Medical Education Committee, Foxy, ICOG Governing Council member 2021-23. And she has done original research work in the field of cancer. And ma'am is a vice president of UPCOG. And past president KOGS IMA, and she is president Kanpur Menopausal Society. I welcome you, ma'am. And our next panelist is Dr. Monika Gupta. Ma'am is ma'am is professor and head of department of OBGYN, AIMS, Vijaypur, Jammu. And she's member of Safe Motherhood Committee, Foxy, and she's teacher for last 17 years with special interest in adolescent health and high-risk pregnancy, and she has done many publications to her credit. Welcome, ma'am. Welcome to the board.
Thank you so much, Dr. Kanchan.
And our next panelist is Dr. Ginny Gupta. Ma'am is chief consultant at Healthline Hospital, Ludhiana, and General Secretary, Ludhiana OBGYN Society. And she's Manita Champion and Coordinator, Punjab. And ma'am has special interest in safe motherhood and adolescent gynecology and high-risk committee, high-risk pregnancy. And she's faculty at state and national level conferences. Welcome, ma'am.
Thank you, ma'am.
Dr. Ranjana Joshi, ma'am, she's HOD OBGYN Department, Tata Hospital, Jamshedpur. President, Jamshedpur OBGYN Society, ex-secretary, Jamshedpur OBGYN Society, peer reviewer in ICOG, journals and international journal. Welcome, ma'am. And Vidhu Modgil, ma'am, she is one of the very active person, and she's director and senior consultant at Suman Hospital, Ludhiana, and fertility expert for last 20 years in New Life in Fertility. And she's past president, Ludhiana OBGYN Society, and past secretary, Ludhiana OBGYN Society. And she has participated in many national and international conferences, presented at many national conferences, organized workshop, and she's active Rotarian for more than 25 years. Welcome, Vidhu, ma'am. And the next panelist is Dr. Shyama Devadashan, and she's chief consultant at fetal medicine at Ambedi Scans, Thrissur, and she's visiting consultant at Apollo Adlux Hospital, And she is Secretary Thrissur OBGYN Society, Master Trainer Dheera, and Initiative for Violence Against Women by FOXI and UNICEF. She is Executive Member, Perinatology Committee FOXI, and Executive Member, Kerala Chapter of SFM, and Member Society of Fetal Medicine and ISUOG. I welcome you, ma'am.
Thank you so much, Dr. Kanchan.
And last but not least, our next panelist is Dr. Saswant Jani, and sir is Consultant Assistant Professor at NHL Municipal Medical College, Ahmedabad, Clinical Secretary AOGS, Chief Coordinator West Zone, Perinatology Committee FOXI, Master Trainer FOXI John Hopkins Safe Motherhood Initiative, published 18 articles in Index Journal, and invited faculty to many national and international conferences. I welcome all the panelists and moderators and kindly request Niranjan sir and Pawan ma'am to kindly take the panel.
Thank you. Thank you so much, Dr. Kanchan, and I welcome all the panelists today on this or common forum for panel discussion. And the topic which we are going to discuss today is a very common topic, that is the LSCS. And LSCS, as we all know, we have been having the cases of LSCS which are on increase. We know that we have the incidents which are rising. We know the techniques are getting difficult because of whatever problem, and sometimes we get unexpected problems during LSCS, and these are called as the troubleshooters. And so many times we anticipate that the section should be really going smooth, but we land up into technical difficulties. Sometimes we anticipate problems, sometimes we get surprises. So these are the common case scenarios. The idea of discussing was that common thing which we can have a common discussion about various practice points, how we go about, and how to make it simplified, because the incidents and the cases of LSCS are increasing, but the problems are still persisting. Just when we begin a sincere vote appeal for a Vice President FOXI West Zone, it is my earnest and humble appeal to all of you to please do vote and bless me and support me. So Caesarean section, as we know, is yet another way out. And this is now the common thing. Patients also know it very well that it is going to be Caesarean section. And sometimes patients are okay with it. Sometimes there is a tussle between the patient, the doctor, obstetrician, and everyone. And this is the historical photos which I just wanted to put to just make the context running. And this was initially how we have come to our level of Caesarean section. It was earlier done only because they wanted a concept that the dead feet after the death of the mother, the fetus and the baby should be buried separately, and that was a concept. And later on, how removing out the fetus that time has now led to a Caesarean section. So this is how the Romans and all the Caesarean section which has come up so much. Caesarean section is now perceived as a safe, simple alternative to vaginal birth. And everybody feels like, even patients sometimes, even doctors sometimes, but is it really that simple? Or there are any problems? Yes, there are. There are so many problems. When there are comparative studies also which we see, which are even listed, the problems or the complications or the maternal morbidity, it is on the rise because of Caesarean section. It is not the other way around. That Caesarean section is going to prevent and going to have a good outcome always. So we need to be prepared with all these problems, and that is the concept of these short cases. So let's go on with cases. This is a primea gravida, 27 years old, 37 weeks. She had a tardy progress of labor. Now she's fully dilated. No further descent, deflex head, transverse suture on per vaginal examination. So we really know she's fully dilated. So you get a call. So you feel it's a second stage arrest. So what next? Dr. Shashwat, I'll begin with you. What about instrumentation? Would you go ahead and do it, or straight away Caesarean section?
No, I will just try only one attempt with instrumentation. If it failed, then I will not do more attempts. I will straight away go for the Caesarean section. I know Caesarean section would be difficult for the delivering the fetal head, but for the safety of the mother and fetus, I will prefer to go for the Caesarean section.
I think we need to have a decision really very at that level only, because we get tempted. that we need to do instrumentation, we need to pull. What about all the panel agree? Anybody wants to add?
Ma'am, I would disagree with Shashwat said, because I would go straight away for a cesarean. No trial for instrumental delivery. Because see, it's already a full dilatation. You've already have a impacted. You cannot, it's impacted. You cannot do it by any other way. It's not going to come out. Already the edema is there and everything. More trauma is going to be there, more lacerations and everything. So just a difference of opinion, probably I would go straight away for cesarean and no trial for instrumental delivery.
I too would disagree, because it is an
Agree.
obstructed labor, impacted head, causing more problems, including vaginal tears along with the cesarean section. So added problems, so I'll directly go for cesarean section.
Yes, agree to it.
Ma'am, station of the vertex is not mentioned, na?
What? Station?
Station is not mentioned.
So the station, now if you feel the station is +1 and it is in transverse occipitous transverse. So what would be your choice?
+1, someone might be tempted to apply a ventouse if the pelvis is very roomy and the baby weight is small, and you know that there is no nuchal cord from previous Doppler scans.
No,
But
Dr. Guinea,
definitely-
no, Dr. Guinea, no. It's already a transverse arrest. Even if you use a ventouse, you're going to cause more of a morbidity associated as compared with the cesarean at this stage. So even if you try, this is not going to be a very fruitful, and we are adding more to the morbidity of the patient as well as the baby. See, because if you try again, you will land up with a failed. So if you look at what the studies say, that you should not go more for trial, because देखो ना impact हो गया है, वो पहले ही फंस गया है, ventouse निकालने से फंसा हुआ नहीं निकल सकता.
See, the idea is that when there is a lot of caput, application of ventouse also becomes very difficult. You know, and the cesarean section also is not going to be very simple or something that we know, but we really need to make a decision that time. And if at all you feel there is no caput and you apply, then you really need to know how many times you will pull before, like if there is no descent or something, it's impacted. You need to draw a line. Yes.
One pull, just one pull. If there is no caput, baby weight is okay.
Yeah,
and
I
is
also
good.
want to say this. Once the baby is in transverse arrest, definitely there has to be a reason for it. I mean, either there had been a mid cavity, the diameter has not been adequate, or there is something with the fetal baby itself. There's a problem. So ventouse is also out of question. There was a one time when we used to think that little bit of rotation is possible, but ventouse is not for rotation, it is just for delivery. And transverse arrest, we should go straight away, take the decision for cesarean section.
So another problem if the head comes with ventouse or whatever you try, come little down, and then you think of section. Section is going to be all the more difficult in these kind of.
So my next question is the same way, that this patient now is coming for section. So Dr. Kiran, can you just tell us, like, what would be the problems we are going to anticipate here? Where would be an incision? And what are the technical difficulties in baby delivery?
Yeah, so basically, the baby has gone up to the transverse, means it has gone inside the pelvis to a great extent. And it must have been there for a quite long time. So first and foremost thing is the bladder might be already little edematous, or it might be high up. So when you are opening the abdomen, first thing you should be careful to give the incision little high up on the upper border of the your incision line, not the lower one, because then there are chances of injuring the bladder is there. That is one thing. The lower segment must be stretched, or the upper segment must be quite high. So you have to select where to give the incision. You have to be ready that this head is already in the arrest. So how to deliver it? Maybe when you just give a nick into the uterine lower segment, there might be a hand coming out, or there might be that the ear is presenting. So that has to be, you have to be ready with the procedure, that what you are going to do, how you have to take it out to avoid, because thin, it must be thin also because of being prolonged. So there are chances of extension and injury to the descending branch of uterine artery. For that, you should take a incision prior only in a curved C, so that the tip of the incision, both sides are little high up. And even if it extends, it goes on that direction. It doesn't go towards the descending cervical.
Yes.
So the chances of giving T or extensions are not there. Then previously we used to think of doing that push method, but now nobody. I mean, that there's, and when we were resident, then we were taught that one person was ready with the gloves and pushing from the down. But that is not now is the thing. It is best to use the Patwardhan's technique to take out the babies, depending on where is the anterior shoulder and where is the back is. So which how the Patwardhan or anterior, posterior, which side you have to take it out. So, and for that one has to be trained for it. So that is the very important thing.
Yes, I think the Patwardhan training is something which we Indians are really very good at, and we always try to avoid and do Patwardhan. But whenever we discussed with the UK statistics, they are really not very well versed with Patwardhan, and they have this pull versus push technique and fetal disimpaction techniques they have come up. So what about the panel? Anybody has used any other technique to deliver a deeply engaged head? Dr. Shashwat?
No, I usually use Patwardhan, or
you can deliver it by the breech also sometimes if it
reverse
is required. Then go to the, you can put a hand and say, hello.
Yes, we can hear you.
Usually, yes, madam, as madam was telling, and Shashwat sir, I think Dr. Shashwat was also agreeing that, Patwardhan is what we all, yes, right from our PG days, our superiors all have been training us in that. So that is the major difference with the UK standards, as Komal ma'am said. When we discuss with them, when outsiders, like they don't agree. They always have this push and pull thing.
Yes.
But for us, mainly pull is also there. That reverse breech extraction or the pull technique. Arul Kumaran sir in Singapore, he had, yes, we all have learned that. It's a quiz question actually, how exactly do you go about it? So that pull technique is important, madam. Other than the Patwardhan also, this reverse breech extraction is also something we all could advocate, depending on the case.
A reverse. Dr. Shashwat was talking about reverse breech, yes.
Yeah. And UK people use pillow, vaginal pillow or tube that.
Yes,
but we are very well versed with this, our technique, Indian technique.
Yes, sir. We don't also have vaginal pillow.
Has any of
we
the
are better in
panelists
this.
used or seen, like, are you all have you all actually had any experience with this fetal pillow? Just a question out of it.
No, we just have seen it in the YouTube and all, but otherwise, no.
Okay.
It is the
no personal
I
experience.
personally I have conducted workshops with RCOG and other things, and basically they are a technique of they are not well versed with Patwardhan at all, because they don't find it simple. They don't know which hand to pull, which leg to remove, which is the anterior, which is the next shoulder, how to remove the trunk. So technically, a lot of training is required, and we are trained because everybody knows it is even in our genes. So as an obstetrician, we are well versed, and that is the reason this case of deeply engaged head and the techniques which they have said, these all are available. But we are using our Patwardhan. That is really very important. And Dr. Meeta, you want to add anything? What are you using commonly?
Ma'am, even though we are teaching Patwardhan to our students, but they are better off with reverse breech extraction. Probably because breeches, they are comfortable. The newer PGs, we saw them using more of this reverse modified Patwardhan, what we also know as the reverse breech extraction. The Patwardhan is probably with our generation. If you look up us in the north here, they are not very comfortable with Patwardhan. They are more comfortable with the modified Patwardhan.
So, Dr. Meeta, would I be allowed to add a line that sometimes when you give the incision, the shoulder pops out, then the decision is made. Patwardhan, it is then. And if the shoulder doesn't pop out, sometimes the baby is flexed and in the way so much stuck into the pelvis, and it is very easy to gently slide your hand, go follow the back and find the foot. And then once one foot is down and you gently ease it out, and then the other foot, and then that is done. So that is the rule we used to follow at PGI Chandigarh, where I'm trained, that if the shoulders pop out, then the decision is made. One shoulder pops out.
That is a valid point, and you should use a technique which you feel how much is the space available that time, and the decision needs to be made really very fast. Because whether you have a person pushing down and pushing, and the technique is very difficult. What happens? The flexion needs to be maintained. Sometimes the people don't push in a proper way. That it is not a two-finger. It is a fist push which is required, and it deflexes the head. And that is a time where there are a lot of extension or problems what we encounter. So I think we Indians are very good in the upper segment. We can rotate or we can do a patwardhan and remove. I think most of them are trained with.
Ma'am, one last point, I will not take much time. The pushing from below is usually, if you don't have, there are sometimes anesthetist does it. In PGI, we had many years back a case, she would just not stop pouring when we did the examination. There was a long tear in the anterior vaginal wall caused by pushing from below. So it's not easy. So that is why in this part of the country, it is mostly, in the resident population at that time, we totally abandoned it. That we will only deliver by maneuvering from above.
And if we are taking the head out, I'm not talking of the patwardhans, if we are delivering by head, the main thing is maintain flexion. That will ease in most of our work.
That is so very important.
Very important
Flexion
point.
has to be seen.
Yes.
It should be there.
Yes. Other than taking care of the bladder in these kind of cases. These are the two things I wanted to add.
Okay, thank you. Now we move on to the next case. Please share the slides. I think we have lost Komal. Requesting you to hold on, just hold on. I am just coming to the PPTs. Yeah, thank you. So we will go to the second case now. Yeah, I would like to share the screen now. Komal, okay, you are back now.
Yeah, I'm back. I'm sharing the screen.
Sorry.
Yeah, sorry. Actually, this was second case.
Actually, we both lost the connection at the same time. Anyway, thank you. So basically, you can see this is a woman. She's fourth gravida, para 2, and previous to LACS. The first was 10 years back. There are no OT notes available. The second is 2 years ago. There she had severe PPH during the operation theater, and hemostatic sutures were put, and there were adhesiolysis when they had opened the second time. She also received 4 units of blood transfusion. And the third one was just 1 year ago, an MTP she underwent because she had frightening experience to deliver. So basically, she has no other medical issues. All the routine investigations were normal. And on admission, the ultrasound showed that the baby weight is 3.1 kg at 38 weeks period of gestation. The placenta was fundal, grade 3, liquor is adequate. She has suprapubic hypertrophied irregular scar. There is no evidence of scars, tenderness. So, and on examination, the baby is cephalic presentation, 2/5 palpable, and the head is floating. Fetal heart rate is 144 beats per minute. On PV examination, os is 3 centimeter, and there is unfazed It membranes are plus, sygnalic high, minimal show is plus. Can we have the next slide, please? Yeah. So she was taken up for a cesarean section and bilateral tubal, tubal ligation with the consent of her husband. 2 previous LACs in this, for cesarean section. So what are the difficulties which you can face while, going through this issue, and she doesn't land up with PPH again? What will be the choice of abdominal incision? What difficulties would you anticipate, and how would you avoid to, injury to the bladder or bowel? So this is what we are facing nowadays, with 2 previous LACs, 3 previous LACs. Dr. Kiran Pandey, you're a professor at Kanpur Medical College, and obviously you have seen so many cases and also taught, and suddenly you get a call, madam, wo bladder khul gaya, madam, wo hum log upar gaye the, khulne gaye the, bladder khul gaya. And sometime even you get a call, wo madam kuch to some I don't know, probably intestine khul gaya, madam, bachcha reh gaya baaju mein. So these are all situations where unfortunately, when in a teaching institute, of course, in a private hospital or a private setup, we are much better off to that extent, and we are much more expertise. But just elaborate, madam, how you could avoid these things and how we can, go through it in a case of 2 or 3 previous LACs.
Yeah,
Beginning from skin incision, madam, which one? Eye, above,
yes.
low.
Yes, thank you, Dr. Niranjan.
Thank you, madam.
Very rightly you said we do get these type of calls in the emergency. So actually, the first and foremost thing is, if this, the best would be the, hello.
Yes, madam, we can hear. Hello, I think we have lost contact. Can Dr. Rekha, madam, take over by the time?
Hello, am I audible?
Yeah, sorry. Yes, madam.
Yeah, so there was some internet issue. Yeah, so what I was saying is the first and foremost thing is the best will be if the patient is coming to us in the antenatal period and she's booked regularly and we are looking since beginning, because that will give us a time to explain her and to properly evaluate the case since very beginning, like she had the PPH, so her hemoglobin should be maintained throughout. What luckily, as per your findings, placenta is fundal anterior, so that part has been ruled out. Third thing is like the most important problem, but still we have to be ready for PPH. Preparedness has to be into the mind. We have to keep into mind that the senior person is available at the time of operation. So the elective cesarean section, because this is a case planned for previous 2 planned for already bilateral ligation, tubal ligation and cesarean. So when all the senior faculty are there, and even the other anesthetist, senior anesthetist is also available. And in our hospital, we always used to book the ICU bed for these cases, because that is the anytime whatever we might do, there might be a problem and she will be landing up into emergency. So these certain preparations then come, then taking of the consent before incision. I will say we have to inform that these injuries can happen, bladder bowel can open, so that part also is very important to be explained. Otherwise, in this era, you have to take care of these things and the patients will complain. Then, of course, when you are, as I said, in all the difficult cases, in fact, I would say you have to keep in mind that the bladder can be advanced and you have to might open up. So the incision should be higher. And even sometimes, although luckily we have been doing since very beginning transverse incision, giving it from my residency, so not a big problem. But if you are not comfortable, you can go for a vertical incision also. And even if you go for a transverse incision, it should be higher and little more liberal. Don't be at all small incision or cosmetic incision. It should be a liberal one, so that you can, if need be, if intestine are available, might be adhered or anything. So you have to look for all the sites where they are. So the field exposure has to be very good. The team has to be very good, explained, and then keeping into mind that the uterus can be adhered to the abdominal wall also sometimes, very bad, and sometimes you don't get at all where to go put the incision because the thick band of the uterus is adhered to the abdominal wall. Bladder is high up. So these are the problems you have to keep. Intestines are there. So keeping these things into mind, you have to give the incision. And if they are there, you have to take care of them beforehand. Just find a way, deliver the baby, and then tackle with these incisions or the adhesions, whatever they are. But unfortunately, even after taking a precaution, if something happens, then we have to be ready with the surgeon is informed and all that can be done.
Yes, madam. I hope you can see this case.
Yes, we can see.
Yes, madam, this is my favorite video. And I don't want to boast, but this is A to Z of LSCS of 8 minutes. It has got 1,20,000 views up till now. And so many members are still seeing it. As you rightly said, that we are now in a situation where we need to only continue with the, supra pubic incision. And these are all adhesions which are there, which we can see. And you need to have a sharp dissection, as you also said. And hopefully, this incision is taken and then we go ahead. The clarity is not so good, but I am sure, I apologize. Once you're opened, it is very important that you open her up high up. It's very important. And there are adhesions. Luckily, the adhesions are not here, but little bit adhesions you can see. We just opened the UV fold. And Dr. Vidhu, you still use the scissor or you use your finger in such situations? See, like here you are using the finger and, your opinion, Dr. Vidhu or Dr. Shashwat also can say.
Sir, I always prefer sharp dissection.
Yes,
with
okay.
Scissor.
Okay. So,
just to
so
mobilize
now
the bladder.
Yes. Now this is what the seniors, Dr. Pandey and Dr. Meera and even Dr. Rajendra Kumar will agree that we use the scissor. But my residents,
Yes.
they want to put their fingers and they want to do that Narsima technique, and then they try to deliver. What is your opinion? Is it better to use fingers or it is better to use, this scissor?
Personally, if you say Dr. Niranjan, I would say it's basically sharp dissection is better where the fibrosis part is there or adhesions. If you find some place when you are dissecting and you find a place where there are no adhesions, there you can use your finger. Otherwise, fingers will not be able to do. It is more of a, in these old cases, usually there is a good amount of fibrosis is there, and then you need a sharp dissection.
Like a difficult LSCS, previous LSCS, expecting additions, big baby, or transfers, and all those kind of things, it is the sharp dissection. If it is a primary and you are not expecting any problems, probably Narsima technique would be fine.
Okay, okay. So I would like to stop sharing now, and
nice view. We could see that clearly.
Yeah. Thank you, madam. And I would request now, Dr. Komal, can you please share the presentation? It's very important to go and open up high up. You should see that, and always try to avoid the bladder. I just want to share one of my SR when I was a registrar 30 years back. He was called to do a cesarean section, and the lady was totally draped, and he started taking an incision. And once he opened the abdomen, he was searching where is the uterus, and he thought that is uterus. He cut open and he was searching the baby, but that was the bladder he had opened, and that is what he found, a Foley's bulb. So this is a situation which anyone can go through. I mean, it's very. Next day, madam came and she gave him a memo, because it's very important that you need to catheterize. Come on, when you're coming, you should at least see that the woman is catheterized or no. So all these small things are there, and we need to understand. Sometimes the bladder is totally advanced. It has gone up till the round ligaments, madam, as you are aware. And even you all will agree, it becomes very difficult. The whole abdominal wall is plastered, and it becomes a very have patience and do gradual, as Shashwat Jani sir said. You need to use your scissors and then cut and go ahead.
Sharp dissection is always better, sir.
Sharp dissection, and once you go in the right plane, na Shashwat, you will just walk in like it just slides down. I mean, it is such a wonderful experience. So I think, are there any other modified entry methods? Let's go on that next.
Generally, we can go with the lateral approach also. Sometimes laterally we can find the window, and then from there we can find the plane between the bladder and the anterior uterine wall. And from there we can push the bladder downward, because sometimes in the center fibrosis is more. As we are going through the transverse incision of the skin, so we can find the lateral approach also. This is another method. Some people are using that gauze piece on instrument and then try to push the bladder, but I don't think that is better. Always I use scissor for with the sharp dissection, sir.
Yes, I agree. They take
like
the sponge holder, on the sponge holder, and they push the bladder down, and then yes, that is also. Dr. Rekha, you were saying something. Please
sorry for the interruption. What I was saying is, in the very beginning, when we open the abdomen itself, catch hold of the parietal peritoneum, and the first incision on the parietal peritoneum will be a very small nick at the very top end of the incision, like the very high part. After, though you are given a Fenton still, the parietal peritoneum incision will be very high, because you don't know where the bladder is. And as soon as you make a small nick, because the atmospheric air gets sucked inside, you will have enough space sometimes, and automatically you will get that place to further proceed, or to see the additions, or get a window where you can gradually proceed. So the very first nick is very important. Don't put that incision low down, because you don't know where the bladder is.
Yes. So I think we have discussed. Can anyone suggest me what is the role of extraperitoneal C-section? We have Dr. Deepak Desai here. He is in Vasai Virar, and he does this extraperitoneal cesarean section in about 11 minutes. What is your experience? Any one of you?
So we have just seen him doing in workshops. Otherwise, we don't have any other experience.
Absolutely. No, he is a phenomenal
yes, sir,
person.
Definitely. But we are not doing it, sir.
Yes, Dr. Monika is there, Dr. Meeta, Shashibala, Guinea, madam. So, I mean, it's very important that I think the best method is the way you are comfortable with, and it's a most easier method. You avoid any bowel handling. There are less chances of any intraperitoneal infection and sepsis. Nowadays, sepsis has increased, like because of a lot of sections happening at in our labor OT, in a tertiary center, 16, 18 sections. The time interval between sterilizing the table, and it causes a lot of infections also, on not only subacute infection, skin infection, but that infection can go and the suture material or vicryl or the uterus. All these things you have to be very careful nowadays. And of course, we are not going to lose any mop inside the peritoneal cavity, and the adhesions are going to be less. So thank you. What are the other strategies during cesarean section to reduce adhesions? What is your opinion, Dr. Vidhu? When you have a case of previous 2 LACS, previous 3 LACS, you have already gone ahead and closed the uterus, uterine wall. Would you like to?
Left. Yeah, she's there. Dr. Vidhu has left for emergency.
Yeah.
Oh, anyone can take this question. We have senior as well as young colleagues.
Basically, what we do it for avoiding the adhesions, one thing is you have to avoid the too much blood going into the abdominal cavity. Number one, for that, I personally do it, put the sponge on both the sides to prevent the blood going into the abdominal cavity. That is one. After you have checked other things. Secondly, handling has to be very precise. It has not to be too much of tissue tearing and other things. They cause damage and later on also pain and adhesion formation. Thirdly, whatever the best hemostasis you maintain, that is also a good thing. Leaving less of the raw areas, that is again very important. And sometimes if you find really, normally no retroperitonization is done now, but if you feel something is very important, then you can do a retroperitonization also. And some people do put certain MCL, etc., or so that the
interseed,
so that
Interseed has been quite commonly used in our setup also, because every 2 previous LACS, and it's really made wonders. Interseed is not
that
only
can also be
gynecological practice, but also in obstetric. Just cut a strip. You have got 5x4. You can cut it into 3 strips, and you can utilize the 1 pack for 3 cesarean sections. See that it is, the whole idea is that you keep it in the uterine incision, the uterus, and that just keep it there. After all the mopping has been done, the hemostasis has been achieved, mop count, instrument count has been done, and when you want to close now the UV fold, or you want to close the the parietal peritoneum, so we just go ahead and put interseed. That is a wonderful thing which is used in obstetrics. And of course we have got Misgav Ladakh technique, and Joel Cohen incision. You have to use scissors wherever it is required. There is always a controversy.
Actually, as Madam rightly mentioned, that these factors we can prevent. We can try to prevent. But some other factors like patient's immunity, patient's nutritional status, anemic status, these are some co-factors that can affect cause adhesions.
Sometimes the body nature itself, like in our hands itself, in the same atmosphere, one patient would have got more adhesions, exact same technique, easier case would have got more adhesions.
Even suture material use and suturing technique also is important.
Yes, I absolutely agree. Thank you so much. Now I hand over
Just
the
one
mic.
question: anybody uses other than phenyl regularly? Once in a way, okay, but what is the most common one used by many of you, just out of my interest?
Commonly phenyl. The Joel Cohen and etc. very rarely sometimes.
Yeah.
Depending on the particular age,
and all.
it is okay.
Fine, thank you.
And now we move on to the third case. A 38-year-old conceived after treatment for primary infertility. She came at 30 weeks. USG is showing, apart from the pregnancy, which is 30 weeks, the USG is also showing evidence of fibroid. And there are 2 on an anterior wall, 6 into 7 centimeter one, and another is 3 into 4 centimeters. So patient is now admitted for safe confinement, corticosteroid cover given, everything weekly, Doppler, all investigations, everything looks in normal. And then at 36 weeks, she had some non-reassuring fetal hearts, and an elective LACS was planned. So now she had a lower segment myoma. So cesarean myomectomy was also performed because she was an elderly gravida, 36 weeks, chronic hypertension, and she had a large 2 myomas in the lower segment. And there were also multiple myomas present in the anterior wall fundal region and subserosal myomas. So these were how the myomas were. This is one of the image, and this is specimen of the myoma. So now my main question is that here we had this patient, we knew she had cesarean, she had myomas in lower segment, was taken up electively, kept in-house, and then a planned and cesarean myomectomy was done. So my first question to the panelists is open. So cesarean myomectomy, whether to do or not to do?
Ma'am, it's a basically controversial question since last 10 years, last decade. that whether we should go with the myomectomy with the cesarean or not. Because some people prefer to do, and some still they are not very because they are scared of excessive bleeding and adhesions and post-operative infection in myometrial bed. So what I think is that if interval fibroid that comes in the lower segment and there in between the at the site of uterine incision, then we should remove it. Otherwise, only subserous fibroid which can be easily removed. Intramyometrial fibroid, if it there doesn't come in between, then it can be lived.
Yes, I think it is a very tricky question. It is a choice because we are worried about the bleeding and other part. But per se, will you give a choice if it is not coming in your way? Are you okay doing a myomectomy, because patient is going to definitely come back and say that I'm going to have problems with fibroid also later. So
yes,
as an elective, is anybody doing myomectomy?
Yes, according to me, yes. Previously, say probably when we were students or even 10 years ago, it was contraindicated for the fear of severe hemorrhage, as Dr. Jani said. But nowadays, everybody is accepting doing it because the only thing is the prior consent from the patient is very much necessary, because we know that in Prabha Manchanda's case, it was done for without consent. So don't do it without consent. Tell her that if it is necessary, I will remove it, and most probably I'm going to remove the fibroid. That's one thing. And second thing is the patient will come back for the second section, so you can avoid the cost and all the other complications when she's coming in near future for a second set of problems and all that. Better to remove the fibroids, whichever you can approach, you think it is possible. And most of the time, surprisingly, or according to the expertise, it is possible. We have removed many of the times the fibroids, especially the bigger ones. The only thing is a proper closure of the bed is necessary.
Yes.
There should not be, the blood lacunae or the whatever you call hematoma or whatever you call, that is perfect closure. It's not a one layer closure or anything. Perfect closure is important. The second thing, what I practice is I exteriorize the uterus and then remove the fibroids, and that would be easier for me to do the cases. Some people may use vasopressin also.
Yes, ma'am. Some people try to ligate the uterine and then do. Ma'am, only one thing we have to, as ma'am rightly said, we have to suture the bed very properly. If you go for the normal myomectomy, the uterus size is normal. And in cesarean, what happens is that because of involution, the sutures will get loosened up within 1 week, or then if you do the sonography after 1.5 months or 6 weeks postpartum, then you can see some blood collection or some hematoma in the myoma.
Yes. So that is very common. So we need to select the cases, do proper closure, check other things. I'm coming to you, Dr. Kiran. What about any techniques which you will do to prevent and reduce the hemorrhage? Because we are worried about only hemorrhage, and we really, they have said, but you want to add anything that what you practice in practice?
No, basically, first thing is that, as Dr. Dekha was saying, consent. Besides that, the preparedness is also very important. I mean, if supposing the patient comes with a 8-gram hemoglobin, then we will not say take these things. So blood has to be ready, the preparedness has to be done. Then, of course, it depends where the with what is the fibroid subserous. It's very, very comfortable. Intramural, then definitely it will bleed when we will tunnel it or do it. So the vasopressin or the temporarily, even uterine, not needed to totally ligate it. It can be like we take the catgut through it, hold it into the artery, and if need be, then you can tie it. So it's not necessary to devascularize completely priorly, specifically the uterine. But if needed, you can do it without anything problem. The anastomosis will take place without it. Then you have to look that uterus has to be contracted. For that, if it is relaxing, sometimes because of fibroid, it intermittently relaxes and contracts. Then you have to give the oxytocin or the, prostaglandins, whatever is required, plus tranexamic acid. These days we are giving. In all the cases, it is said that beforehand, if you give that, it decreases the blood loss. And then, very rightly said, the suturing has to be very adequate. And again, I would emphasize that these things have to are also important, that only that person should try who is confident of it, who has been doing it, unless, I mean, don't have to experiment with these things, because then you might end up into trouble.
Yes,
So
ma'am.
these are
Removing fibroid is easy, but suturing is very difficult. So you have to be
suturing
expert.
is more difficult.
So
Yes.
message is very clear that the person who is experienced person, we should do it. It should not be done because somebody has done it and I want to see and do it, because believe me, you'll end up into a lot of problem, lot of bleeding.
I would suggest that you please call a senior person when you are just starting your practice and you are probably 5 years down the line also. Always call a senior person, because obstetric is it just turns
Unpredictable.
suddenly very unpredictable. You might never expect things can go wrong, and when you never expect things to go wrong, they go wrong. So
yes, and blood should be ready.
Definitely, a
blood
senior
should be
person
ready.
and blood should be ready.
And it's very important nowadays. I mean, just to leave a fibroid inside and come out, the doctor, when the patient goes, "Arey, वो डॉक्टर साहब ने आपका सीजरियन किया और गांठ नहीं निकाला क्या?" So this is how our own people talk. So please understand that we are all one fraternity. We should give a clear-cut message. Do not ever talk things, what retrospectively could have been done or now, because it's very important. A person at a senior level has done a section. He has left that fibroid for the reasons the best is because it is not accessible through the incision. It is intramural, or it is a situation where a tunneling also, if done, it's very difficult to close that cavity. So you have to understand the situation. It's very easy to, just pass a statement. So it's very important. Please do not denigrate your own fellows, own colleagues who might be next door neighbor, because any situation can come across to you. Always try to understand that if a senior has not done it, probably there is a reason which is the best not to be done. So you just don't go and try to do something which is very important. Dr. Kiran, I hope you will agree, because you are a past professor, head of the department, sitting in that MDR meeting, sitting in so many government, committees, quasi-judicial. So it is very important.
100%, 200% I agree, because many a times cases do come for inquiry, also have headed many inquiries. And there you have to be very, very careful in passing. Even if you find like the judgment, the I think judiciary also says negligence is the problem. It's not decision, can be individual also. If the person finds competent and comfortable, only then it will be done. With me, I have done a rule. Whenever a patient wants to, or attendant wants to tell me, ये उसने नहीं किया, ये नहीं किया, I always say, देखो, मुझे when I was not there, I cannot comment. आप अभी की बात करो, आपकी प्रॉब्लम क्या है, मैं उस पे बात करती हूँ. पुराना हमें जब पता नहीं है उस चीज के बारे में, we can't say. There must have been situation, there must have been reasons because of which this decision was taken. So this is how we should always be there and try to save
I think it's very important. We should help our own colleagues. We should be courteous enough to be, helping them and try to, reduce this issues. And I think surely it will make a lot of difference. Please continue, Dr. Komal.
Yes, just I think the advantages are enumerated. We know that there is no separate surgery required, and sometimes, but we should not. We really need to outweigh the advantages when we select. It should be a case selection. It should be selection of a particular case. It should not be a generalized thing that you have to remove it. And really, it is on the decision making of the person who is managing the case rather than making it a general statement. And there are some problems we know we don't want to come into a medical problems, but if there is a pedunculate myoma, it's a simple one, easily approachable, serosal one, and you feel it's a large one on lower segment, that is the one which we need to remove. I can see Dr. Ginny also here around. She wants to add anything before we move on to the next case?
Ma'am, I think yes, sir is very right in saying that people will, when you come out of the OT, they will ask you, Nikala nahi abhi? So this is antenatally, the counseling has to be done. Careful when you are doing the antenatal ultrasound, careful mapping, dekho kahan par hai. And those big fibroids projecting into broad ligament with huge vessels, it is madness to touch them. This patient has history of infertility. Well, anterior fibroids we removed, okay. But if it were bigger, I would be very, very upset. We might land up in a cesarean hysterectomy, or at a later stage, she might have a hysterectomy from postpartum hemorrhage. So I think that pre-planning and sounding it to the patients that we may not be able to do it. It is important to come out through the surgery with the best results for you. This should be the teaching, because many patients talk about this, that why didn't you remove it? This is the commonest problem. बच्चे को भूल जाते हैं, फाइब्रॉइड तो निकाला ही नहीं आपने उनको. Then I explain to them कि फाइब्रॉइड के साथ ही तो बच्चा हो गया, एक और हो जाएगा, फिर निकाल देंगे.
I know.
Yeah.
Dr. Komal, can I add one thing?
Yes.
Yeah, and whatever we have done, like the coring, tunneling, the suturing, how many myoma were there, how many were removed, how many are still remaining, etc. Should come in the discharge summary along with the diagram. And many of our patients, we know that they do not come back to us for the second delivery. That too, having a previous cesarean section, they may go to some other place. So they have to carry the discharge summary where we have mentioned everything with the diagram.
Yes, it should be really very important, because what happens is that we are removing a myoma, but later on the patient needs to carry it, and we need to know how was her antenatal course.
Yeah, so that next doctor will be able to understand. Thank you.
Yeah.
Let's move
So
to
I
the
think
case 4.
I will move to the next case. Case 4. Can you see the?
No, there's a screen share has stopped. Yeah, start now.
Yeah. So this is also a very interesting case, madam. And 32-year-old woman, Gravida 4, Para 4, 3 living. The first is the cesarean 8 years ago. Second is a 6 years ago cesarean done. Then a third cesarean done 4 years ago. So you can see there are 3 cesarean sections, and the weight is approximately 2.7, 3 kg, 3.1, 2.8. And now she is registered with a 35 weeks of gestation with false labor pain. So on the outside ultrasound, here you have a case of placenta previa, and it's quite common now. We get placenta accreta spectrum, cases also where it has totally invaded into the bladder, inside the dome of the bladder, and all these things. But here we don't have any evidence of placenta accreta symptoms. The patient got admitted, everything was fine, and the head was floating, and per abdomen she's about 36-38 week size. On per speculum examination also no bleeding. Heart sounds are fine, regular. On admission she was monitored well. Fetal heart recordings were taken, blood pressure, all the investigations were fine, daily kick counts were taken, and then a planned cesarean section was done at 38.2. Baby, a female, was delivered. Apgar score was 10. The birth weight was 3.150. Intraoperatively, following the delivery, the placenta accreta, it was suggested. So obstetric hysterectomy was done, and the patient got 2 packed red, red cell volume, and 4 fresh frozen plasmas were also given. She made a good recovery and was discharged. So I'm sure you might have also got such patients. And when you get such patients, I would like to ask Dr. Rajendra Kumar, madam, how can you diagnose this adherent placenta in antenatal period? Please throw.
Yes, in the antenatal period, the first thing, sometimes very rarely what we make diagnosis is the cesarean scar pregnancy, which we make early diagnosis in the first trimester itself. And these kind of cases are almost 100% known to go to the PAS kind of problems. So that is the only thing most of the time diagnosed in the first trimester. But otherwise we get suspicion in the late second trimester or in the third trimester. Though there are certain blood parameters we are not comfortable, or the inference is not so perfect, so we go for the proper ultrasound diagnosis. of the placental accreta syndrome, like whether it's a whatever kind, like by the ultrasound we make the diagnosis. Not only the routine ultrasound, even the Doppler gives us a lot of information. Yeah, Doppler also gives us a lot of information, like the routine ultrasound itself tells us about you should get a high index of suspicion when you have especially the placenta previa, especially in a case of previous section, and the ultrasound shows a lot of vascular, the lacunae there, or the hypoicokaria is missing between the placenta and the myometrium, or the myometrium has become very thinned out just below that placenta. Even the transvaginal ultrasound is not a contraindication for this kind of cases. MRI is necessary only in a very rare cases. More than 95% of the cases we make the diagnosis just by the ultrasound itself. But one thing I would like to say here is that sometimes it may be vice versa also. Like you don't diagnose in ultrasound, still you be prepared. Whenever there is a placenta previa, be prepared for PAS. This is one thing. And second, sometimes surprisingly, the ultrasound may give a diagnosis of PAS and you may not find it. The brighter side of it, you may not find in the case. So it need not go hand in hand, but be prepared having all this together. That is previous section, plus or minus previous section, plus placenta previa with ultrasound findings, whatever I have mentioned, plus the Doppler findings. Be prepared, like the antenatal admission, beforehand admission, blood hemoglobin, ready her with the proper hemoglobin, etc. The MRI we do, but MRI is not always indicated, only indicated when you are not very sure of the ultrasound, not an experienced ultrasonologist, etc. Certain times the cases it gives extra information, like that into T2 imaging, that vertical bands of placenta, whatever we call, or bulging of the uterus or bulging of the placenta, etc. Certain information we do get, but most of the times we go by ultrasound.
Yeah, absolutely. And the sensitivity, specificity, if you compare that with an ultrasound and MRI, it's much better. And of course, affordability is also to be seen. But in such rare cases, nowadays, MRI is available in, I will tell you, India has progressed so well. You will find MRI in all tertiary centers, whether it is a corporate hospital or a teaching institute, except for peripheral smaller hospitals. It is quite very helpful in such situations. And as you said, madam, you have to take this with a pinch of salt. Always any report whichever comes, you have to always take with a pinch of salt, and that is very important for us to understand. So here you have
man behind the machine is more important, and also we should give proper information to the sonologist.
Yes, reporting is very important, madam.
Yes, man behind the machine, plus we also should help them by giving some indication. Not a routine fetal well-being scan. When you write the scan requisition, it should not go just as a general scan requisition.
Yes.
Yeah, thank you.
Yes, madam. Thank you. Dr.
Sir,
Dr.
there
Kiran.
is a line I would just like to add. Sorry to interrupt you. This is a line from an old obstetrician of PGI, that if there is a placenta previa and she has never bled in pregnancy, understand that this may be adherent. Because in this patient, it has been missed. Although with central placenta, we will prepare in the same way. They are as bad. They are worse maybe, because they are the same team. We want embolization OT to be ready, everything. But this is an old saying from a very senior obstetrician. If the placenta previa has never bled even once in pregnancy, that's very suspicious. Major degree placenta previa, it may be adherent into the myometrium.
In fact, one which bleeds little bit, it is better.
It's not adherent.
Yes.
Because there is some line of separation. There is some vein for separation. Here it is so adherent.
Yeah, the scenario is changed. Previously, when there used to be a bleeding in placenta previa, we used to be scared. But now, since the placenta accretas in the past has become so common, so now some bleeding is a good sign. Scenario has changed totally.
Dr. Kiran, I am coming to you only. Now we already know that this is a placenta previa or say placental, spectrum accreta or whatever. I mean, it's a very higher. So what incision would you prefer now? Would you like to cut the placenta through and through with a funnel steel, or you want to take a classical incision, going like this, or inverted C-shape incision?
No,
And
no,
how
no.
to-
With the placenta accreta, no chance of giving incision on that lower segment or C or cutting it. Absolutely,
Yes.
totally
Those
no.
days have gone now, madam. We were taught, you go inside through the placenta, separate it, and then
No.
you approach the baby. All
No,
things have
now
gone.
specifically in this case, she has had it. This incision has to be, I mean, you have to see the vasculature, the prominent vessels. Above that, you have to take the incision to take out the baby, and only then. Otherwise, where it will start bleeding, not bleeding, in fact, say pouring, and then it will become very difficult for you to manage that. So it should never, your incision should never cut it. I mean, clearly you can see those prominent, very highly vascular lower uterine segment. So
And also the lower uterine segment is very thick, because you are taking a section not at term. You are taking probably 34, 36 weeks. The lower
So
uterine
you have to
segment
go
is
above it.
vascular.
Yeah,
Yes.
and one thing is that once you diagnose that it is a placenta accreta, because it keeps on invading. So as soon as the maturity comes, even like you have to take a decision to terminate little earlier than normally required, because
Yes,
you don't
yes,
want
yes.
to percreta. Up to accreta, increta, you can manage it more comfortably. But if it is a percreta going into the bladder, then even in expert hands, and even with all the facilities, there are more and more complications and risk to the mother. So
Madam, madam, I agree with you. It is all this is all a man-made obstetrician, man-made situation. I think after 10 years, every second patient you will have placenta, percreta, and accreta, because see the rising trend of incisions of Caesarean section is increasing, and every third, fourth section, you will have such a situation that every second, third patient, not placenta previa, but the placenta is adherent, morbidly adherent. So we have got 2-3 things situation, and never try to, understand all these things. Keep blood. I have seen patients with B negative blood. So what do you do in such situations? You have to be very careful in, going ahead to post this case. So if the placenta fails to separate, there is no other choice. Be ready for an obstetric hysterectomy. There is something like, systematic devascularization
and embolization.
Embolization, yes. All these facilities, you have to weigh the pros and cons. And this all things are to be available. Always never do this in a nursing home. Please, I advise, shift this patient to directly a tertiary center or a corporate hospital. Never do the mistake of trying to do heroism with some senior also, because you never know how things can turn up in such situations, and it's very important. So I think it's already covered here. We have to perform the very planned preterm Caesarean hysterectomy, placenta accreta. You're not going to keep it inside in our Indian medico legal situation, because we want to avoid the massive hemorrhage. And the uterus incision must be performed at a point far from the placenta. Conservative approach should only be considered in case of there is a strong desire of a future pregnancy, and this is very important. Well, the role of medical management of placenta accreta. Anyone, of course, some people have left the placenta, inside, and they have given methotrexate. It is also time tested, but you have to be very careful with Indian scenario that there are higher chances of sepsis, because the people come in our strata of situation. It's very important that everybody cannot afford meropenem and vancomycin and all these things, so or piperacillin. So you have to understand the situation and accordingly treat her. Now, what is systemic devascularization, madam? Please share your experiences, Dr. Rajendra Kumar.
Sir, what I do usually is first of all, as we have told, all be prepared, etc., etc. One is I would, as you said, I don't do in my nursing home. I take it to a higher center and do the case with the senior, prior admission, all the things which we have discussed. The second thing is take sutures, which are the prominent vessels there in the lower segment beforehand itself, so that to certain extent the blood supply is reduced there. Then the second thing what I do is a uterine artery.
Uterine arteries.
Yes, the second thing is I do the uterine artery ligation. The little bit lower, see the uterine artery properly and ligate the uterine artery so that the pressure head is reduced in most of the cases. And internal iliac ligation, yes, I do some of the cases, but uterine artery ligation is my more favorite one, and most of the cases mine I'm quite happy with that. And as you said, if it is a percreta kind of situation, definitely it is a cesarean hysterectomy what we go for.
Yes, madam. I absolutely agree. There is a uterine, ovarian.
The ovarian also, you're right.
Uterine, ovarian arcade. So actually the first film which is here, it shows you the uterine ovarian arcade. I will reduce the volume. Yeah. So, madam, as you said rightly, you need to ligate the uterine arteries on both the sides. And if you see the fallopian tube, it's very important that this is also an old film. Please forgive me. You know, so here you have the arcade. You need to totally see the fallopian tube, the broad ligament.
Keep it
and
away.
Yes, and here you have to take that arcade, 2-3 sutures, and you will, because if you stop the uterine artery, you have the ovarian artery also, which is giving the blood supply to a certain extent, so that you avoid. So these are also the 2-3 sutures you take, and of course internal iliac ligation. This is also a very simple technique. We have been taught by our masters, and I'm sure there is always a one master in our town. He's always there to guide us, and he is always there to support and be ready. So you should have one senior person ready to go ahead with his internal iliac, and see once the uterus is the delivery of the baby has been done, the placenta has been still delivered or it is still intact, you need to go retroperitoneally. Please, I apologize for the film as much as, because it's very difficult to go through the whole light and go and approach retroperitoneally. But here, if you see, you have to open in the same way. Actually, at the infundibulopelvic ligament, and then once you opened, you have the internal iliac artery, external iliac artery, and it is going to the uterine artery. So the anterior division, always tie the anterior division, never cut. So we usually use the black silk or the linen double equal, and through the mixture, it has to be passed, and then we ligate it. You need to have 2 ligations. So this we had done in one of the case, and just gently just ligate, and you should always do bilateral. There is nothing like unilateral, there is nothing like unilateral internal iliac ligation. You have to do a bilateral ligation. So we were here. Yes. Any further comments, madam? Dr. Kiran, your experience with internal iliac ligation? So many internal iliac ligations have saved to go ahead with an obstetric hysterectomy. Your opinion on that?
Yes, I mean, I would say in today's scenario, with this pass increasing so much, every obstetrician has to be familiar with it. And the best thing I always tell my postgraduates, that it is, I mean, in emergency, you will not learn. You have to do when you are doing a normal case of hysterectomy or anything, that time you do like anterior approach or posterior. I am comfortable with the posterior approach and go for that, and show. I try to show in every case that this is because unless and until you are absolutely familiar, in that pool of blood, you will not be able to do anything. So first thing is, if you need it, compress the uterus. One assistant is required to press the uterus so much the bleeding doesn't happen. Another is for, I ask them to do the aortic compression so that we are able to at least see the place. And then, of course, the site and everything is there. You know that the 2 centimeter below the where the division, because we have to see the posterior division should come out, and then anterior division specifically we have. So one should be familiar with it and practice it when in a normal patient, because the uterus is gravid. When it is bleeding, it will not be possible. And today we need it a lot. So it's a very important surgery, thing which everyone should be trained into it and be perfect with it whenever you might require. It can save many of these techniques.
Yes, even embolization.
And
madam,
embolization is not available in all medical colleges. Even our medical college doesn't have the facility of embolization in our department.
He comes only twice a week, and you will have to post it in such a way. The guy who is capable, he comes only twice a week. Probably he's an honorary consultant hopping from one hospital to another. And we need to also have that in mind. And the cost also, it varies. In our hospital, it is costing 25,000. So depending upon the cost and everything, probably in a corporate, it might be more than that. But it's very important that the catheter is inflated and then it is deflated after the completion of the procedure, and successful balloon occlusion of the abdominal aorta during Caesarean hysterectomy for placenta percreta has also been described. So, well, the failure rate is not so much, but obviously the complication rate are also very high. So you have to be very careful. There is some triple P procedure. You have to understand that the gynecologist, not the oncologist rather, you should first plan the uterine incision. The second P is for pelvic disc vascularization by internal iliac artery ligation. And third P is for placenta non-separation with resection of the myometrium. And as you suggested, there is a modified aortic occlusion. So I think we have covered all the aspects of managing such difficult situation. Well, this whole discussion can go on and on. There are various difficult cesarean sections to be done in transverse lie, in impacted fetal head, in a preterm, baby with floating head, or a multiple twin pregnancy, modified Patwardhan's technique, and so on and so forth. And there is always a reverse breech extraction technique. And the discussion can go on, but due to paucity of time, we need to wind up with this. Whenever I am in a difficult situation where there seems to be no way out, I think about all the times I have been in such situations and say to myself, I did it before, so I can do it again. And always pray to God that this patient goes home with the baby in her hand. And that is the best and the most wonderful feeling which we get and we share with the patient and the relatives. That's what we are here made for as an obstetrician, to reduce the maternal morbidity and mortality in our country. All of you are all superheroes, and all of you are veterans. And what more can you give to the society back by making them aware of, teaching them, of giving back what you have gained so much experience. I can see Shashwat Jani, I think more than 15 years of experience. Rekha madam, Kiran madam, I think 40, 45. I don't want to increase, you look so young, but still the amount of energy which you have and the so many techniques which have come is surely going to make a lot of difference to our viewers. I just came to know we have probably crossed 550. If you compare that of 4,500 in COVID and 550 today at 8 p.m. is fair enough for us. And please do watch us on YouTube also. It is there live at the Shield Connect and on Dr. Komal Chavan's video. And this you can also access on the Shield Connect platform. So I would like to thank all of you who have come, especially Dr. Kanchan Prasad, Dr. Monika, and all the esteemed panelists, the chairpersons who have been there, all of you who have come and joined us and spending your valuable time. Without you, we cannot be here.
Thank you so much,
So,
sir.
Thank you so much. It was a wonderful
Thank you, Komal
discussion.
ma'am.
You planned very
Thank you.
nicely.
We had a lovely discussion, and thank you all for joining.
Thank you, madam.
Thanks to all the panelists. The panel discussion was awesome. Everybody are really doing great work, and the messages were very clear. And it was a fabulous discussion. So thank you.
Thank you,
all of
Komal. Specifically, I actually completely forgot. So,
yeah, good.
But I could join in time and I hope I could contribute.
Dr. Komal and Dr. Niranjan, thank you for the vibrant academic session. Before we close, I would just like to add one point that we agree that a lot of cesarean sections increased, etc. Because of that, our morbidity and mortality, according to me, has very much come down. But whatever, the placental, whatever we call spas, also has increased. I agree. But it is fortunately for the third or the fourth cesareans, the incidence is more. And many of our girls are stopping luckily at the second one. So best of both the worlds, we are somehow managing. Thank you.
Let's have a balance and everything.
Yeah.
I would like to thank Chitra and Dr. This Chawda and the whole team, Prachi and Kedar sir, for being there with us. And thank you again, Dr. Kanchan and Dr. Monika and all the esteemed panelists and chairpersons who were there. See you soon.
Thank you. Thank you.
All
Bye.
the best.
Thank you, sir. Thank you so much, sir.
Thank you, Dr.
All
Rekha.
the best, Komal, for your future endeavors.
Thanks, Dr. Rekha, very much. Lovely discussion. Thank you, Dr. Kiran, for being on time. Kanchan, bye.
Thank you so much for giving me this.
Bye.
Very nice. Bye. All the best.